what happens. If I'm lucky. I don't know, here I thought we had. But let's try to go. Good afternoon and welcome to bill hearings for the House Health and Government Operations Committee. I'm your chairman, Jocelyn Peña-Melnick, joined by my wonderful vice chair to my left, Delegate Bonnie Collison. I'm going to go through some rules that we follow in this committee so that it can make our life easier. I ask for your patience, first of all, if we encounter any technical or streaming issues. I'm going to start by practicing what I preach. If you will be so kind and place your phones on mute or vibrate so that you're not embarrassed if it rings. Hint, hint, no? Okay, please. All right, you've been better. I appreciate it. As a reminder, there is no food or drinks allowed in the gallery because then our staff has to clean it, okay? For each bill that we hear, we're gonna hear from the bill sponsor and the sponsor panel. Oh yeah, I dropped my, then I forget it, so I have to go for it. The sponsor panel, and then we're going to listen to the witnesses. The witnesses get 2 minutes to present their testimony. When they present their testimony, a timer is displayed on the screen and it will sound, a sound will play when your time has expired. I don't want to be rude, so I respectfully ask you to just, you hear it, wrap your thoughts up, okay? So that I don't have to interrupt you. The bill sponsor in this committee, I decided I will not time because you have to explain the bill, right? And everybody else is limited. However, don't abuse it. Don't make me have to stop you. So maybe 5 minutes. For our wonderful committee, I want to thank you because you guys have been working so hard and the public doesn't see it, that this is around the clock. And I thank you for the work you're doing to get these bills through, to listen to people when they come, and for being on time and in subcommittee and in the committee. And I am so grateful. And to our staff who have been working really hard, I can't thank you enough. Those of you that are listening in the office, also the interns, we have amazing interns and fellows this session. I want to thank them for their research, their writing, and their work. It takes a whole village to do this work in the committee. Members of the public, you'll be able to view this live stream on the Maryland General Assembly website and YouTube channel. Today, we will hear the bills in the following order. Now, keep in mind that I may change it. If for example, I call a sponsor and that sponsor has another hearing in another room, like you'll see us getting up. It doesn't mean we're not interested or not paying attention, is that we also have bills in other committees. However, we have access to these recordings and we also have the bill file that we get beforehand and read it. So the order as of now, it will be the following. House Bill 1253. Delegate, will you please come up and bring your panel? And I believe you have Cornelia Bright Gordon. And you have a virtual Seth Miller. Will you be so kind and bring them, please? I appreciate it. And then we have House Bill 1190. And then House Bill 1396, House Bill 790, House Bill 65, House Bill 1100, House Bill 1194, House Bill 1475, House Bill 1476, House Bill 1497, and House Bill 1498. If I may ask, 1 second, is this the number one? Who is here for House Bill 1475? Yes, will you be so kind? Marie Grant, can you please raise your hand? Marie's in the back. Your bill will take a little while for us to call. Can you be so kind and will you be so kind and step into the conference room for a second? Thank you so much. If you could talk while we have the rest of the hearings. Is it Laura? Yeah, I appreciate it. Okay. And is there anyone from Montgomery County for this bill here? No? Okay. All right. So let's go on to House Bill 1253. Let's get started. I want to thank everyone for your patience, okay, as we establish the rules. Go ahead. Good afternoon. How are you?
I'm doing well, Madam Chair. How are you doing today?
I'm doing great. You do not look like the delegate.
Can promise you I know as much about this bill as the delegate does, as well as I have as many grades as the delegate
I
does as
don't
well.
doubt
So-
that 1 minute.
The delegate has asked me to speak on his bill on his behalf today, as he had some other obligations. So if that's acceptable, I'd love to provide an explanation as well as my personal story for this bill.
Yeah, give us your name and you can get started.
Well, thank you. Good afternoon, ladies and gentlemen. Madam Chair, Madam Vice Chair, distinguished members of the House Government and Operations Committee. For the record, I am Keith Michael Gazier, Delegate Metzger's intern. Delegate Metzger is the sponsor of House Bill 1253, which is cross-filed as Senate Bill 813 in the Senate. Thank you for this opportunity to speak with you today. House Bill 1253 is about installing landlines in healthcare facilities. In the age of smartphones, this bill may seem redundant. However, I can assure you that this is not the case. When I was in Army basic training at Fort Sill, Oklahoma, I was required to escort a fellow trainee to the hospital. He had fallen ill and required immediate attention. We were not provided with our smartphones as we were taken immediately to the hospital. Air was escaping from his lungs into his chest cavity. A combination of illness and intense training took its toll on his health. Luckily, the hospital had a landline in his room, and we were able to inform the trainee's parents about his condition and that he would be all right. The opportunity to talk to his parents and hearing their relief was a great boost to his morale, and he quickly returned to training and graduated with us on time. Without landline access, his parents would have been in the dark about his condition. My fellow trainee would have carried that concern with him throughout the rest of the cycle and impacted his ability to graduate with us and serve our country. For these reasons I have discussed, I respectfully request a favorable report on House Bill 1253. Thank you for your time and your consideration.
Can you give us your name again, please?
Keith Michael Gazier.
Okay, thank you. The next, please.
Greetings, Madam Chair, Vice Chair. My name is Cornelia Bright Gordon, and I am the Director of Advocacy for Administrative Law for Maryland Legal Aid. Thank you for giving me the opportunity to come and speak with you again today. You have my written testimony in support of House Bill 1253, and I'm going to ask you to consider who resides in nursing homes and assisted living facilities. Consider the protections that the General Assembly has created to protect them, and think about who they are and what they look like. My clients are frequently amputees, bilateral, arms or legs or both. And frequently, when I go or my staff go to see them in assisted living facilities, there's no telephone there. They can't reach out to the Office of the Ombudsman. They can't reach out to complain about their care because many of them do not have cell phones anymore. My clients are low income and they're not receiving the happy outcome that the delegates intern just reported on. And they're there for the long term. They can't complain. Now, I'm carefully watching the timer, but I think it's off.
It is, well, but don't worry about it.
Okay, thank you.
If we haven't said
I'm not
anything, you know what you do? Don't say
I'm not
anything.
trying to take advantage.
That's what I would do if I was sitting there.
Yeah,
Go ahead.
I just want you to know I'm not trying to take advantage.
It's okay. I appreciate you.
So Maryland Legal Aid strongly supports this bill. It provides protections to those who desperately need it, but can't ask for it themselves. Many people who are there in assisted living or nursing facilities are there for the long term, not the short term. And for my clients, many of them are there for life. What they have to do is they have to waive attorney-client privilege. And if they can, roll their wheelchair out to the nurse's station and speak in a public-facing format or forum. They might have to ask their roommate for a cell phone. And we as attorneys carefully try to watch attorney-client privilege. And in those cases where they're being evicted from a nursing facility or evicted from a nursing, from an assisted living facility, we can't give them advice that's safe and secure. They can't reach out if they want to complain because their diapers haven't been changed all day, they have not gotten their medication, or that they feel that they're in danger. They may have fallen out of the bed. A confidential, reliable telephone connection is important to protect my client's rights and include avoiding an order of guardianship. For all of these reasons, Maryland Legal Aid supports House Bill 1253. And also for all of these reasons, we drive all over the state in order to effectively communicate with our clients and potential clients. Thank you for your attention and the extra time.
You're welcome. And you did have the extra time. It's okay. Mr. Miller, Seth Miller. You are muted, sir. Love to hear your voice. You're still muted. It's okay. Take your time.
Madam Chair and Committee, can you hear me now?
Yes, we can. Thank you.
Madam Chair and Committee, I'm Seth Miller. Thank you for your service. Delegate Metzger, thank you for introducing this bill. I was the one who originally asked Senator Salling to introduce the Senate version. While not in the script that I presented, I wanted to discuss something the young lady from Maryland Legal Aid said. When the other residents in skilled nursing found out that I was a paralegal, they were asking me questions that I was not able to answer left and right. So she's absolutely right that it is essential that patients be able to communicate with their attorneys. I was a patient at Potomac Valley Nursing and Wellness. The name changed. It was a dump. They renovated. My experiences are not unique. My ability as a younger patient to testify is. My first night I was in a room with 3 other men. One got up and battered a paraplegic. Without full use of 3 of my own 4 limbs, I could not help. It could have been me. The 2 were separated. A nurse on duty would not call the police. I told her she would call the police or I would call the state. Police report attached. The next night, my roommate was slapped by a staff member. I called the police with my iPhone. Increased patient phone access will be an incentive for staff and patients alike to behave. Phone access will be a strong deterrent. I'm no expert in combatives, but I think that in a space that small, response times what they are, a victim using a phone during an actual attack is unlikely. A landline would be tougher to neutralize than a mobile phone. Patients will be able to communicate with outside doctors as well as family. I can only imagine how isolated patients must have become during COVID. Does anybody have any questions for me?
Okay, we will open it up for questions in a minute. Thank you for being with us. Just hold on 1 second. Is there a Jacob Leffler here? Will you be so kind and come up? Thank you. And also Stevan Ellis. Oh, she's virtual. Can you bring her up, please? Yes.
I proceed? Hello. Hello, my name is Jacob Leffler. I am the Vice President for the Maryland Association of the Deaf. Nice to see you all again. I was just here earlier this week or last week. I don't know. I feel like I've been here every single day, but I'm here to talk
We
about
love seeing
this
you.
bill. Oh, well, thank you so much. I'm here to testify in favor of House Bill 1253 for telephones in healthcare facilities. Maryland Association of the Deaf has offered a amendment along with our written testimony to this bill. We are in favor of it. There's roughly 1.2 million deaf and hard of hearing, deaf blind, late deafened people in the state of Maryland, and many of them are senior citizens. They could be in nursing homes, rehab facilities, and hospitals, and so forth. Many of these individuals don't have any access. They don't have the right equipment that they need to be able to make calls to our families, our attorneys, our friends, and so forth, our doctors, and so forth. They don't have the right devices for us in the deaf community, especially with telecommunication devices and the internet. Now, why do I mention the internet? Well, it's because currently many deaf people are using video phones that require us to have the internet in order to make phone calls with individuals. Right now, oftentimes hospitals, nursing homes and so forth, they have poor internet connection and the video streaming freezes, so we can't communicate. We've heard many stories from deaf, hard of hearing, deaf blind individuals in our community saying that they are in these facilities and they don't have devices in which to communicate. One person needed to make a phone call, very critical phone call. They went to ask someone at the nurse's office or whatever to make a phone call for them. Where was their confidentiality? They had to trust that person to make the phone call for them and inform them of the result of that phone communication. We want direct communication via video remote interpreting, VRI, video relay services, amplification phones, and so forth to make our phone calls privately in our own room. So I'm asking you to consider the amendments that we have offered to meet the needs of the deaf and hard of hearing, deaf blind, hard of hearing, latent deafened, to give them the access that they need in healthcare facilities and hospitals so that we have equal access, telephone access for all. Thank you so much.
You're welcome. Thank you for being with us. I am going to, I believe Stevan, oh, Ms. Ellis, Stevan. Why don't you give us your testimony?
Great. Thank you very much. My name is Stevan Ellis. I'm the State Long-Term Care Ombudsman. I'm the Director of Advocacy for Nursing Home and Assisted Living Residents. I'd like to thank the Chair, the Vice Chair, and other members of the committee for hearing my testimony today. I'm asking for a favorable vote on this with one amendment. I think most of us do take the telephone use for granted. This bill will allow residents to have a phone in their room. What does this mean for the resident? Currently, in many cases, there's not a phone in the resident's room, which means that they have to use the facility to phone to make calls, which often means at the nurse's station or they have to arrange for a telephone in an office. And this is very difficult for many residents. In common areas, it can be very loud. There's a lack of privacy, and some residents aren't able to leave their room at all or are bed bound. The amendment I'm asking for is for each resident to have their own phone in their room rather than sharing it with the roommate. I think that would really help a great deal. Often we think of cell phones as an appropriate use. Many residents don't have the ability to use cell phones. They may lack the physical ability or the cognitive ability, and hearing may be very difficult. So I'm asking for a traditional landline type telephone. It also makes access to mental health services and healthcare services to make calls when you need issues addressed. And if you use Echo or Alexa, or if you want internet connection, having a landline can make life a lot easier. It really, even for me, the most important thing is it helps with social isolation. Having an ability to talk to people, your friends and family and others, having that phone so you can have private conversations to talk as long as you want is really important. And I believe this should be available at no cost to the resident. I'm requesting a favorable report for this bill with amendments, and I appreciate you taking the time to hear my testimony. Thank you so much.
Thank you for being with us today. I'm going to open it up for questions now, since all the witnesses have testified. Are there any questions? I see Delegate Woods, followed by Vice Chair Collison, followed by Taveras.
Thank you, Madam Chair. So I certainly thank you for the legislation. You thank the delegate, please, for the legislation, and certainly understand the need for having access to telephones. I'm looking at the fiscal note, and it's saying it would talk, Maryland Department of Health is saying it's going to take about $10.2 million in fiscal 2025 to put a telephone in each individual patient room. And so that's the first concern that I want to talk about. But the other thing is, and I'm trying to think out of the box. The last person who testified just kind of made me have to back up to thinking out of the box. She made the statement, because I also understand that there's social isolation, right, for folk who don't have access, and that can have a major impact on their mental health. And you made the comment about being able to talk as long as they want, kind of community kind of thing. But I was trying to think out of the box and wondering if you know, if there was a protocol whereby so that you did not have to put a phone in each room, if we could have something like a phone room on each hallway that was kind of separated so that people could go in and have phone time. And I'm talking specifically as it relates to maybe trying to reduce that cost because that would be a major barrier. Any thoughts on that?
So to answer your first question, the delegate is aware that the cost of this bill is high and recognizes that before this bill was necessary, hospitals already had a multitude of phones, a multitude of operations to already facilitate this bill beforehand. And phones were removed as a cost-cutting measure, so that way hospitals could operate more effectively. So if these phones were not removed in the first place, then this bill would be unnecessary. There's also concerns about that hospitals would not be able to implement this because of the space and the requirements. But once again, the delegate raises that argument of these phones were already in hospitals and were removed, that capacity is still there. The delegate would also like to highlight the impacts to community towards patients' health and the ability for them to speed up their recovery by having this community, this connection to their families, their friends, once again, their communities. And the costs of that is priceless to Delegate Metzger. Concerning your second question as to whether or not he would be amenable to a solution concerning perhaps providing these spaces that were once available in hospitals, he is open to amendments to make this, to reduce the fiscal impact on hospitals, but still providing access to patients with or without disabilities so that they can still have this community and communication with their family and friends. Thank you for the question, Delegate Woods.
So I have a follow-up. Did the delegate meet with the Maryland Department of Health prior to this hearing?
He did, yes. It was yesterday, I believe. Yesterday, yes.
Yesterday, okay. And did he meet with the Maryland Independent Living Network?
No,
Okay, and did he meet with Lifespan Network? They represent most of these facilities.
we did, yes.
You met? And what was the discussion?
We discussed the practicality of this, of their concerns. I apologize. I was not present
Oh, it's
personally at
okay.
these meetings. It was our chief of staff.
No, it's okay. You're doing quite well. All
I
right.
appreciate it. Thank you.
Okay, so I'm going to go ahead with some of the questions. And I have next, I believe it was. All right, Vice Chair Collison, followed by Taveras.
Thank you, Madam Chair.
You're welcome.
And thank you for presenting today on behalf of the delegate. He is well represented. I don't know if you're going to know the answer to this, but perhaps we might be able to get it through the Department of Health. There must be a certain percentage of facilities that already have this in place. And so I guess I'm wondering what percentage already has them, and if there is a way to phase in. I think this follows up from Delegate Wood's question in terms of, you know, if we start from a foundation of facilities that have them, then how do we build in? And I understand the need for some accommodating equipment for those with hearing impairments and also with sight impairments, I suspect as well. So two questions. Do we know what percentage of facilities currently have these in place? And two, is there an openness to sort of phasing in the program over time and giving the facilities a longer time to achieve this goal?
Thank you for your question. Unfortunately, I don't know the answer to the first one, so we will provide that information as we get it. As far as the second question, there is an openness to extending the period for it, because I believe the bill is 2025, January 1st, 2025 is when they would like this implemented. But if the delegate understands that this does take time, takes money, raise the funds, and we would be open to extending that out to give hospitals a chance, and forgive me, healthcare facilities a chance to phase in this program.
Yes.
Just a quick comment. Follow up. one of the things the delegate might also think about is how is negotiating with the telecommunications companies, the various ones, because I suspect we might be able to work with them. And I would say the same thing to the Department of Health. So just something to think about.
Thank you for your question.
Delegate Taveras,
Thank you, Madam Chair.
you're welcome.
So I'm reading the letter from Lifespan, and they did express concern. Well, they said that there is a cause for reasonable access to these phones in their facility, and that's what's there and that's what's law. With regards to the phones, is this accessible to facilities that provide psychiatric care? Is there a concern for harm?
If I may, the letter from the Department of Health addresses that point and makes
Okay.
that point.
Okay, yeah, because I was looking
Yeah.
at it and I just saw the figure.
Yeah,
I saw
it's
the
in
10 million.
It's in their letter.
So they raised the same
Yeah,
concern.
they raised the same concern you raised, Delegate.
Thank you.
You're welcome. Any other questions? Seeing none, I do have a suggestion. Given that that it's very costly, it doesn't mean that the committee does not support it, because it's the right thing to do, right? Communication is important. However, we know that this is a balancing act. So what I like to do is I like to ask, we have letters from AARP, the Maryland Legal Aid, Lifespan Network, Maryland Association of the Deaf, Maryland Department of the Health, Maryland Hospital Association, Maryland Independent Living Network, Disability Rights Maryland, and I just added the telecommunications company. I'd like you to ask the delegate to convene a work group in the summer with the people that I just outlined to try to come up with some solutions. And I'm gonna ask the Maryland Legal Aid to be an instrumental player in bringing everyone together. And what I will do to make it easier is that I will write a letter to the delegate saying this and asking him to convene people and bringing all these parties together. I will ask them to participate, okay? Just
Thank-
because I know that it will be not possible to get it through. This is crossovers Monday, the bill is late, it has a huge fiscal note, and there's so many people that are not, they have concerns. That doesn't mean that I'm not committed. It just means that I want it done right. And that I want to make sure that we get it done, okay? As well. So I will tell my staff, actually, if you could follow up with my staff, with Michelle, let her know what I asked, and we'll draft a letter, okay?
Thank you
How
so
does that
much.
sound?
Sounds very good, Chair.
All
Thank you so
right.
much.
You're welcome. So this actually, 1 second. Thank you. So this actually concludes the bill hearing on House Bill 1253. Thank you for being with us. Let him know that you did an amazing job. All right, and from the Maryland Legal Aid, thank you. Thank you for caring and for bringing these issues to us. And sir, and everyone else, thank you for being with us, okay? You have a blessed day. All right, and he left, Mr. Miller. Oh, wait, the students, can you come here a second? All of you, will you be so kind and come up? All right, I believe that we have in the House Baltimore city students, they're student government leaders. And I would like the committee to welcome them. Okay, so what you just saw was a bill, right? That wanted to mandate that these facilities have phones for people in the hospital, nursing homes, all these facilities. And it's a good argument, right? Because it's the right thing to do. However, you have the other side that discusses, well, it costs a lot of money, over $10 million, right? For one facility, and they can't afford it. So we're listening to it, we're asking questions, and then we decide. So what I decided in the middle of it, usually I don't, but is that we're gonna do a work group in the interim, because we're in session January until April, so that we can come together from May to December and meet and see if we can come up with a solution. This is how your government works, okay? Excuse me? Oh, I would like the Baltimore City delegates to introduce yourself. Delegate.
Thank you, Madam Chair. Welcome Baltimore City student government leaders to our committee. It's nice to see you again. I'm Delegate Robin Lewis. I met a lot of you this morning, and you see that I work on the Health Committee. And I hope all of you will be back next year as pages, and then after that as interns. And I think my fellow Baltimore City delegate wants to say a few words.
I'm Delegate Sandy Rosenberg. A few years ago, I was a student government leader.
A few years ago.
They think I'm old. In a certain Baltimore City public school that has a castle on the hill. I guess I don't know my audience,
No.
but I certainly agree with what Delegate Lewis said, but would add, you can come back as a page, and maybe even you can come back as a member of this legislature. Good luck.
Delegate Bandari.
And who won the game this fall, by the way? Thank you. Thank you, Madam Chair.
Delegate Bandari.
Thank you, Madam Chair. Even though I don't represent Baltimore City, I represent Baltimore County. However, I've been teaching in Baltimore City for decades, and thank you. Welcome to our committee, and thank you for your character, commitment, and confidence for whatever you do advocating Baltimore City. Thank you.
Well, thank you for visiting us. Okay, it was such a pleasure to see you, and I hope your path is blessed, okay? Run for office, okay? Take care. Bye-bye. Bye. You're welcome. May we have House Bill 1190, Delegate Ruth, as promised. And we're going to bring your sponsor panel, which is Linda Burnborn, Mike, Diana Ignore, Robin, and Bonnie Raindrop. And you have someone online that wants to testify?
Yes, thank you, Madam Chair. I do believe some of my panelists are online on
Yes.
Zoom.
Okay. Will you be so kind and bring them up? And will you be so kind and get us started, Delegate?
Thank you,
And-
Madam Chair.
And you know what? I was told, we have a rule in this committee that if you have a bill with a lot of witnesses, you have to buy dinner for the committee. You may just have to do that. No, just kidding you. Go ahead.
Thank you, Madam Chair, Madam Vice Chair, members of the committee. It's great to be back here again today. For the record, I'm Delegate Sheila Ruth, and I'm here presenting House Bill 1190. I think this committee knows, but just as a refresher, PFAS are forever chemicals. They're ubiquitous, posing long-term threats to the environment, animals, land, water quality, and human health. The health impacts of PFAS include reproductive effects, developmental delays, increased risk of cancer, immune system issues, and increased cholesterol levels and/or risks of obesity. And PFAS persists in the environment. They don't break down easily, but also that means they persist in our bodies as well. So whereas a small amount of PFAS might not be enough to cause human health issues, as it accumulates over time, it can really cause some serious problems. The Maryland Department of the Environment has issued a consumption advisory for 15 species of fish due to this contamination. As I said, PFAS is ubiquitous, and we really have to start, this body has already taken steps. We need to continue to work on that. In the 2022 George Walter Taylor Act, Maryland already banned PFAS, thanks to members of this committee, in firefighting foam, product packaging, and carpets. But pesticides have a potentially broad impact. There's a quote from Kyla Bennett, who is a Public Employees for Environmental Responsibility Science Policy Director and a former federal regulator, who said, if the intent was to spread PFAS contamination across the globe, there would be few more effective methods than lacing pesticides with PFAS. Think about it. We're spraying spraying pesticides containing PFAS on the food we eat and that we feed our children. It also puts workers applying the pesticides or working in the fields that have been treated at increased risk of these health issues. HB 1190 takes a simple approach to the problem. It restricts the sale and use of pesticides which contain known PFAS chemicals as an active ingredient on the label. So no testing is required. This completely eliminates the concerns about problems with testing. There are known chemicals that meet the definition in the bill. It's as simple as looking up those chemicals, figuring out which ones are used in Maryland's pesticides, and then those would be banned for sale and then ultimately banned for use. And in fact, the Pesticide Coalition has done the research to look up these chemicals. They've identified 66 different compounds that are PFAS that are used in pesticides registered in Maryland. And there is a list of those in the testimony, so you can see what those actually are. The EPA maintains a database of chemicals called ComTox, and that the chemicals that the EPA considers to be PFAS are marked that way. There are approximately 14,000 PFAS chemicals listed in the ComTox database. And as I said, 66 of those are used in pesticides registered in Maryland. So we're not requiring testing. We're just relying on the manufacturer who disclosed on the EPA label a particular substance that they've used, as they are required to do by the EPA. So the transition so it avoids the need to identify also whether PFAS contaminants are leaching from the container, which I know has been an ongoing concern, how to separate that from intentionally added PFAS. The transition wouldn't be difficult. Out of 14,000 pesticides registered in the state of Maryland, fewer than 8% are known to contain PFAS. And all of those have alternatives that are already registered. You may hear opponents say that the definition is too broad. I'm not a scientist, but there is a letter in the testimony from the Maryland Pesticide Education Network from a number of scientists asserting that the definition of PFAS in this bill is correct, and also explaining why it's important to use this definition. And in fact, the definition in HB 1190 is consistent with the definition already in law enacted in the 2022 George Walter Taylor Act. So we would be keeping consistency. There are also a couple of other bills working their way through the session that use the same definition. This definition is also used in 22 states, have codified this very definition into law. It's also the definition used by the Department of Defense and by Congress and by 37 nations, including the United States, who are members of the Organization for Economic and Cooperative Development. So this is a widely accepted definition. Sometimes the EPA uses different definitions in different situations, depending on what they're trying to measure or regulate. But in this case, the compounds here were all identified as PFAS in the EPA's ComTox database. And I just want to quickly mention, you may hear opponents talk about things like bleach, medications. This bill does not cover those. Medications are not covered in the bill at all. And while bleach is sometimes used as a pesticide, that's certainly not the intent of this bill. And bleach itself is not PFAS. But we are certainly open if we want to put in amendments to say this bill doesn't apply to bleach, it doesn't apply to flea collars. We're certainly open to amendments to clarify that. So, and we're also open to amendments changing the dates. It was suggested that some of the dates might be too soon they need more time for transition. So that's perfectly fine as well. So this bill is an easy to implement yet critical step in our efforts to curb the release of PFAS chemicals into the environment. And I ask for a favorable report for HB 1190, and I turn it over to my panel, and I'm happy to answer questions after the panel. Thank you.
Before I do that, is there a Sarah Sample here? She's not here. Sarah Sample? All right. Who would you like to go next?
Okay.
Go ahead.
And then good afternoon.
Good afternoon.
Thank you for the opportunity to testify in favor of this bill today. I am Dr. Michael Ikniowski, representing the Maryland chapter of the American Academy of Pediatrics. Children and fetuses are uniquely susceptible to the effects of toxic chemicals, a vulnerability to minimal amounts that contradicts the commonly held misconception that the dose determines the toxicity of a particular substance. An 8-week fetus weighing approximately 5 grams is comparable in size to the insects targeted by pesticides, and PFAS have been shown to cross the placenta and enter the fetal circulation. Low-level exposures during this time of rapid brain and organ development can have significant, long-lasting impacts. I've included a list of toxic effects from some of these fluorinated PFAS pesticides in my written testimony. Because PFAS persist in the circulation and the environment, the potential for lifetime exposure and accumulation in children is substantial. By eliminating the use of pesticides that are PFAS chemicals, we can reduce children's exposures and lower the risk of toxicity from PFAS accumulating in their bodies. Prohibiting the use of toxic substances is often met with resistance from companies that sell and use these products. This happened with lead when industry successfully fought its removal from paint and gasoline for years, resulting in several more generations of lead-poisoned children. The sooner you can eliminate a toxic exposure, the sooner children will be protected. Any discussion of the economic impacts of this legislation must include the increased cost of medical care for affected individuals and the cost of environmental cleanup of these persistent chemicals. Healthcare costs will be borne by patients, providers, and insurers. Environmental costs will fall to state and local governments and the taxpayers that fund them. House Bill 1190 provides an opportunity to prevent toxic exposures before they occur, which would protect the children in this state. Maryland AAP requests a favorable report. Thank you for your time.
Thank you for being here with us, sir. Next, please.
Can we have someone virtual?
Could Linda Birnbaum speak next?
Thank you for this opportunity. I'm the former director of the National Institutes of Environmental Health Sciences and the National Toxicology Program, and I previously conducted research at the EPA for 19 years. The widely accepted OECD definition, which you've heard referred to, of PFAS is considered the international scientific definition and is used by 22 states, the Department of Defense, and our Congress, all aligning with your Maryland's definition in law. You may hear that EPA's Office of Toxics has a working definition that would reduce the 15,000 plus PFAS to 6,000. This doesn't mean that more than half of the PFAS are no longer classified as PFAS. EPA allows its programs to define PFAS relative to their distinct scopes of work. But EPA's Tox Chemicals Dashboard, which is key in EPA's PFAS analytical tools, is currently identifying over 15,000 chemicals as PFAS, including the 66 pesticide active ingredients. Many of the 15,000 and more PFAS are not intended products, but result while making the products or during the life cycle of the products. Many chemicals break down into other chemicals, and PFAS break down into other PFAS. They're often more toxic and more persistent than the original PFAS that were intentionally produced. It's detailed in my testimony. This bill focuses on pesticides whose active ingredient is PFAS. And I want to note that HB 1190 explicitly restricts known PFAS and pesticides only. It does not pertain to PFAS in pharmaceuticals or any other products. PFAS can cause harm to so many systems within our bodies: our livers, kidneys, immune systems, our metabolism, reproduction, and several.
You muted yourself.
No, I think.
It's all right. Take your time.
Sorry.
Go ahead. It's okay. No problem. Go ahead. You can.
Thank you.
You're welcome.
Given that 14,000 pesticides are registered in Maryland, it behooves the state to at least ban these 66 EPA identified PFAS active ingredient pesticides. To help protect future generations, we need comprehensive state policies to end unnecessary uses of PFAS prior to EPA setting federal policies. I urge this committee take a crucial, simple step in protecting Marylanders by passing HB 1190. Thank you.
Thank you. And thank you for being with us today. We really appreciate your testimony and your time. Next, please.
I'm going to go. My name's Diana Eigner. Thank you for this opportunity. I'm a biologist and a toxicologist and a retired EPA scientist. I work as the science director for the Maryland Pesticide Education Network. And as noted by Dr. Birnbaum, it's really important to have a definition of PFAS because of the implications for legislation and for regulation and litigation, and also for monitoring and future research. And if you have an inaccurate definition, you're really not protecting Marylanders' health and the environment. So I like this line, we can't redefine ourselves away from toxics like PFAS. To clarify, Maryland has those 66 PFAS pesticides, but it's in 1,091 products where PFAS is the active ingredient. And again, this bill is for pesticides, not for pharmaceuticals, not for industrial chemicals, not for Clorox. So you know it's called a forever chemical, and that's because it's so persistent. So you'll hear about half-lives. And once again, with half-lives, it's where half of the compound degrades. And the important thing is these degradates can actually be more toxic than the parent compound. And as we're going, it has fluorine in it. That's not going to disappear. It's an element. So you might wonder, how do you get exposed? And it's most definitely from your food and your drink. Once PFAS is absorbed, it really doesn't go through a normal metabolism, and it ends up binding to your proteins that are in your liver and also in your blood serum. And just quickly, I like this, like the cost of doing nothing. I kind of like this part. So the cost to remediate and put these retrofits on drinking water and wastewater treatment plants is billions and billions of dollars versus restricting these 66 PFAS pesticides. Okay. So thank you so much. I urge you to pass HB 1190.
Thank you very much for
Yes.
being with us. We're going to go now to your virtual panelist. Ms. Raindrop, will you be so kind and please give us your testimony? You can unmute yourself, please. Thank you.
Yes, thank you very much. I really appreciate this opportunity and your kind consideration hearing this bill early too. Ruth Berlin was my backup, so she won't testify today. I'm Bonnie Raindrop, Director of the Smart on Pesticides Coalition of 114 organizations and businesses dedicated to protecting the public and the environment from unnecessary toxic pesticide exposures and promoting healthy alternatives. I will be brief. I wanted to highlight that MDE's George Walter Taylor Act PFAS Action Plan released in December clearly states, and I quote, MDA will consider a pesticide product adulterated if PFAS is found in the formulation itself, end quote. And this is important because it provides the directive for pesticides with PFAS active ingredients to have their registrations revoked. And I think it's a critical basis of the bill. There are also many registered alternatives for the known PFAS pesticides, as you will hear, and they can be swapped out for other products that target the same pests. I strongly feel that it's time that we turn off this PFAS tap, and this is a really excellent way with a group of uses where the pesticide is can easily be replicated by other products for its purpose. And, you know, it eliminates a lot of unnecessary PFAS pollution. Our 114-member coalition urges a positive report on HB 1190. The longer we wait, the more unnecessary impact these pesticides will have for generations to come. And I'm happy to answer questions. Thank you.
And thank you for being with us today. We really appreciate your time and your efforts. Is there someone else virtually?
Yes, I think, Robin, are you virtual?
Robin has been trying to get in, but he hasn't been able to. He's a
Is Robin?
entomologist.
It's not coming up. Yep, not coming up on
So we
the,
could maybe do this
now?
panel.
Okay, now he
Well,
came in. Okay,
Thank you.
no problem.
Okay, that's great.
So
If I may ask, while he comes up, why don't we go ahead and open it up for questions, okay? In the interest of time, and I'm gonna look to my right, I have Delegate Kaiser, followed by Hutchinson. Delegate Kaiser.
Thank you, Madam Chair. Delegate Ruth, I have a super quick question and then one that's maybe medium. First, does this bill ban pharmaceuticals and health products?
no, Delegate, thank you for the question.
All right, and then the longer question is, looking at the opposition testimony, there's a mention from the Department of Ag that we should wait for the EPA. Can you or one of your panel suggest why we should move now? Thank you. Thank you, Madam Chair.
You're welcome.
Do it in 2 minutes.
Who's the person
I
that can
can-
best answer that?
I can
One person.
give a brief answer to that. The reason is it would take longer for the EPA to act on this. The federal government, can do its best to try to protect us from different toxins, but it's often driven by legislation at the state level. States like Maryland, which have been on the forefront of environmental legislation, have the opportunity to protect against PFAS chemicals that are used as pesticides. By eliminating that, we can take a step ahead and protect our children in this state sooner than waiting for an EPA ban that might take years to occur. It's like with lead, for example, it took several decades between when lead was known to cause problems until it was actually banned by the federal government. And in that interim, several decades worth of children were exposed and lead poison because of the delay in the federal government's action on it. So I think that's the main reason, is that we can do things faster here than the federal government can.
Okay, thank you. Delegate Hutchinson.
Madam Chair.
You're welcome.
To Delegate Ruth, and I'm sorry if you already explained this in your testimony, but last year we did pass a bill to study PFAS, right?
Yes.
And did that study conclude?
Are you talking about the MDA report that was issued last?
The study that we passed last year, and what was the conclusions of the study, if it has concluded?
Who wants to address that?
So that was.
I want, Ms. Raindrop. Go ahead.
Bonnie, that'll be great.
Yeah.
Thank you. Yes, that bill was to look at testing options for pesticides for PFAS. And the result of it was that the study thought that we should, there was a proposal in there that it would take a significant amount of income for MDA to be able to assess all of that themselves. And that since there was this confusion about working definitions and so forth, that it was not something that, should be moved forward on. And the great thing about this bill is that it doesn't need any testing whatsoever. These active ingredients are listed usually right on the front of the pesticide. And so they're easily identified. These can correlate directly to EPA's current existing database with the ComTox database. And so we don't have to have that step of testing anything. It's already been defined by EPA, and the manufacturer has already listed the name of these particular 66 PFAS active ingredients right on product labels. So it's simple. We don't have to worry about testing.
Madam Chair, may I add one thing?
Usually we don't, but go ahead.
That's fine.
Go ahead, go ahead.
Thank you. And thank you, Madam Chair. Just really wanted to quickly say that you may hear some of the opponents say that report recommended, waiting for the EPA, but that was, as Ms. Raindrop said, specifically about testing.
Yes. Okay. Any Delegate Bagnall?
Chair, and I'm going to try and keep this question shorter than the answer. But looking at, since you won't have an opportunity to speak after the opposition spoke to the report from MDE, and that it said to follow the guidance of the EPA. There is references to the strategic plan from the EPA. which looks like it's 21 to 24, and we are in 2024. And just reading from the report, it says, harmful are an urgent public health and environmental issue facing communities across the United States. The risk posed by PFAS demand that the agency attack the problem on multiple fronts at the same time, integrated approach, research, restrict, remediate. So would you say that this approach is consistent with the recommendations of following the EPA and the EPA's recommendations that we have a comprehensive effort?
Do you want to? I want to say that that report was focusing on analytical methods. And we're really lucky EPA Office of Water, January 31st, put out all these new methods to determine PFAS in different things, water, surface water, tissues, biosolids, the whole bit. So we actually have this new analytical methods, and Maryland can just use those because they were finalized. So I think going forward, using what the EPA has released is really helpful to the state.
Okay, thank you. Any other question for the delegate and her panel?
Right.
Okay.
I'm sorry, Madam Chair.
Delegate Ruth, I'm going to ask you a follow-up. Is there something else you would like to say?
Thank you, Madam Chair, and I appreciate the answer. I did just want to clarify again that testing is not required. So it's great that the EPA has developed these testing protocols, but this bill does not require any testing.
Exactly.
Thank you, Madam Chair.
Thank you. I don't see any other question for this panel, so I'm going to call an unfavorable panel next, just to be fair and balanced. I want to thank all the witnesses for making time to come to here. We really appreciate you, okay? You have a blessed day. Thank you. Next, we're going to go to an unfavorable panel. We have Bernie. Did I see him? Mr. Todd, we're gonna come to you after this panel, okay? All right.
Okay, thank you.
You're welcome. Thank you for your patience and everyone else that is waiting for their bills to be called. Patrick Coakley, Karen Reardon, Tyler Ha, Charles Barton, Lindsay Thompson, and Michael Groover for this panel. If you could bring up a chair, that would be great. Bernie, nice to see you.
Thank you, Madam Chair. Bernie Marzick from Cornerstone Government Affairs here today in respectful opposition to House Bill 1190. I'm actually here today on behalf of the Maryland Farm Bureau, Crop Life America, Delaware Maryland Agribusiness Association, all of whom you'll hear from shortly. I have submitted written testimony from Delaware Maryland Agribusiness Association, and to your point, Delegate Hutchinson, I'd like to focus on the study that was done by the Department of Agriculture, the Department of Environment, and the EPA and the Department of Health in the interim. It wasn't really just focused on health. It was focused on, it wasn't really just focused on testing. It was focused on numerous items. That report was issued back in October. And it is in the testimony that I submitted. It's also, there's a link to it on page 4 of the fiscal note for you all to have a look, and it was sent to you in October as well. I just want to highlight a couple of items from that. First, the report said, quote, after reviewing available literature and governmental data, there's a lack of information concerning the contribution of PFAS and pesticide formulations to the impact of PFAS in the environment and exposure to humans. And second, it recommended to follow the EPA's lead. We would encourage this committee and the state to follow EPA's lead when it comes to PFAS as it relates to pesticides. So I will let you all look at the report and our written comments, but we would ask for an unfavorable report on House Bill 1190.
Thank you. Next, please.
Thank you, Madam Chair and members of the committee. I'm Karen Reardon with the Trade Association RISE. We represent the companies that manufacture the pesticides that would be used by consumers and professional applicators here in Maryland in non-agricultural settings. I think it's important to know that all aspects of pesticide distribution, sale, and use, as well as stringent safety standards and oversight are established in federal law under the Federal Insecticide, Fungicide, and Rodenticide Act, as well as in existing Maryland state pesticide laws. The EPA and Maryland Department of Ag both have the responsibility for ensuring that the pesticides registered here in the state can be used safely. I'll add that pesticides are indeed unique substances with more scientific data available about them than for any other products in the marketplace today. All pesticide products, regardless of their chemical structure, must be assessed and registered by EPA before they can be offered for registration here by the Maryland Department of Agriculture. These products, I'll remind, provide protection against harmful and invasive and non-native pest species, including insects, rodents, and weeds that can threaten the health and well-being of people, pets, places, and the environment here in Maryland. We're asking the committee to rely upon the scientifically rigorous assessment done by EPA and on MDA's existing pesticide regulatory program. This is so Maryland residents can continue to have access to the products they need for their own critical uses. Thank you for the opportunity to share our perspective, and we ask for an unfavorable report on this.
Thank you. Next, please.
Madam Chair and distinguished members of the committee, my name is Michael Gruber. I'm with the Household and Commercial Products Association. HCPA's members manufacture a variety of products, including household cleaning products, aerosols, antimicrobial pesticides, disinfectants, and consumer pesticides. These products are essential tools for a wide variety of functions necessary to maintain clean and healthy homes and institutional facilities such as hospitals. The U.S. Environmental Protection Agency conducts rigorous scientific assessments prior to pesticide registrations. This includes evaluating chemical-specific data to ensure products can be dispersed safely and without unreasonable adverse effects to the environment and when used as directed. Last year, in accordance with SB 158, the Maryland Departments of Agriculture, Health, and Environment alongside the US EPA convened a work group to report on PFAS in pesticides. Within the report, there were recommendations allowing Maryland to follow EPA's lead on developing testing methodologies for pesticide formulations. Additionally, the work group recommended that the state analyze formulation registered with the Department of Agriculture State Chemist Section to acquire baseline data to make policy determinations. The Maryland Department of Agriculture reported to the legislature last October that it would monitor the US EPA's effort to further regulate PFAS and pesticide products. The department also stated that it would review the confidential statement of formulas for all 13,575 pesticide products registered in the state to determine if there are PFAS compounds in those pesticides. The Department of Agriculture also stated it would work with EPA to make registration determinations. HCPA is concerned that HB 1190 threatens to put policy ahead of science and undermines existing regulatory processes by the state and the US EPA. HCPA urges an unfavorable report on the bill. Thank you.
Thank you very much. Next, please.
Thank you, Madam Chair. I'm Charles Barton. I'm an associate certified entomologist. I work with American Pest. We are a member of the Maryland State Pest Control Association. I wish for an unfavorable report on in opposition of the HB 1190. We only use pesticides that are registered and approved by the Environmental Protection Agency. We depend on these materials to help control mosquitoes, ticks, bed bugs, termites, and etc. We protect the health and safety of our customers through using an integrated pest management approach. We follow approved methods of control to include sanitation, exclusion, cultural evaluation, mechanical controls, and using of non-chemical monitors and traps. We only use pesticides when we have exhausted all other methods of control. We protect the public from diseases and viruses that can be transmitted or vectored by insects and rodents. We train our pest control professionals to properly apply these materials and follow the properly labeled rates and to protect our insects like bed beneficial insects like pollinators to protect the environment, and we want to protect our customers. Without these materials in our toolbox, it can become impossible to control them without using these types of methods to help the public and to control disease vectoring pests. Some of these insects could be economically damaging, like termites to destroy a home or bed bugs to invade your house, mosquitoes to transmit diseases like dengue fever, West Nile virus. Our ability to control these insects will be greatly diminished. This is why we're in opposition and we wish for an unfavorable report for the Maryland HB 1190. Thank you.
Thank you for your testimony. Who will be next?
Hi, my name is Patrick Oakley, and I am here today representing both the Maryland Turfgrass Council and the Mid-Atlantic Sports Field Managers Association. And we are in opposition to 1190. Much of our membership of the people that are out using these products that we're talking about today, and our group is, I want to stress, subject to fines or jail time if we misuse these products. So I say that to stress the fact that we are educated, trained, and licensed by the state to do so. So one of the things I want to stress again is when you take away a tool, we need an effective replacement in order for us to do our jobs. And our number one goal is to keep the athletes safe that are on our playing fields. And that goes to golf, that goes to landscape, and anybody that might be on the surfaces that we treat. So what I want to ask is, who sets the standards if something like this is passed? What is the level of tolerance for, damage that insects cause, damage that a disease infestation on a field or a golf course? Who is going to set that standard? There are a lot of people in our professions that are our members that can lose their job because of act of nature. And that has happened many times in the past. Ask the guys in golf and they can tell you many stories. So please just consider, the consequences of a bill like this. Thank you very much. And I'm here for any questions.
Thank you. Who will be next?
Thank you, Madam Chair, members of the committee. For the record, my name is Tyler Huff. I am the Director of Government Relations for the Maryland Farm Bureau. As a grassroots organization, our policy that guides us in our advocacy here in Annapolis comes from the grassroots level and comes from all our members in the county. Our Maryland Farm Bureau policy urges that we support scientific research done at the federal level in regards to PFAS and the regulations. EPA is currently working on those regulations, and we can all say it is a work in progress as they continue to roll out more information and discover more about the forever chemical. This bill would actively ban roughly 66 active chemicals found within pesticides within the state. Ultimately, that affects things such as readily available and cost-efficient crop protectants and weed management tools. With that, the portion about cost really being brought to the forefront, because maybe these alternatives are more expensive and ultimately that cost would be passed along to the consumers. This bill would ultimately put Maryland farmers at a disadvantage as they continue to grow the food, fiber, and fuel for our state. Maryland Farm Bureau respectfully urges an unfavorable report. Thank you.
Thank you very much for being with us today. Next, please.
Good afternoon, Madam Chair, members of the
afternoon.
committee. My name is Lindsay Thompson, and I am here today on behalf of the Maryland Grain Producers Association. I also work with the Delaware Maryland Agribusiness Association in opposition to this legislation. I want to first say thank you to Delegate Ruth for being willing to speak with us and work with us on this. Unfortunately, we were unable to come to an agreement. Madam Chair, you asked me to speak with her due to some fundamental and ideological differences in opinion on the science of this issue. I did want to point out that the report that was put forth was not only by the Department of Agriculture, but it was also Environment, Health, as well as the US EPA. And while the primary purpose of that report was to look at the testing methodologies, it also was asked in the last section of that bill last year to examine the state and EPA evolving science on banning or limiting PFAS in pesticides. So that was part of their recommendations as well. We fully believe that the risk assessment for framework at EPA for pesticides is really state of the art and above and beyond any other product that comes to market. And so we believe that we should defer to EPA on this issue, not only from a scientific and expertise perspective, but also so as not to disadvantage Maryland farmers. No other state has fully implemented policies such as this. And if Maryland were to do so, as you heard Tyler say, that would be taking tools out of the toolbox for Maryland farmers to fight not only weeds, but also pests, invasive species that can be really detrimental. And they also help us to practice some conservation practices like no-till and cover crops. And so we don't want to disadvantage Maryland farmers comparatively to the rest of the country for arbitrary reasons. Thank you.
Thank you. Have all the unfavorable testified? Is there anyone that's missing? Anyone here for this bill unfavorable that has not testified?
I believe we have virtual, but
Virtual? Who do we have virtual that is unfavorable?
Mano Basu, I believe, as well as Amanda.
We're gonna call, there's three of them. I'm gonna call them later. I'm gonna go back to favorable. I'm trying to be balanced, right?
Yes, ma'am.
So we're gonna open it up for questions. Now I'm gonna start with Delegate Hutchinson.
Thank you, Madam Chair. My question is for Ms. Reardon. So I looked up quickly, pestfacts.org, and so you're a national trade organization. So you probably can answer this the best. How are other states handling this situation?
Well, right now, only 2 states have passed laws for all manufactured goods and substances that would include pesticides. So that's Maine and Minnesota. Maine is having great difficulty implementing its law and has gone back to amendments being considered right now within the legislature on a law that passed 2 years ago because it's not implementable. In Minnesota, they've just begun this work. And there is deference there acknowledging the stringent regulation for pesticides within its Department of Agriculture. They will be working on the pesticide piece of that law. So I would say 2 states have taken this up. The others have not with respect to pesticides. Some states have expressly excluded pesticides from their manufactured products laws that are taking up everything because of the regulation we have and because of the body of data that's required to put a pesticide out into the marketplace.
Absolutely.
So Ms. Reardon, you also mentioned there was a difference in terms of the definition between the EPA and what the bill cites. Could you share that with me?
Yes. So the Office of Pesticide Programs, which is within the Office of Pollution Control and Toxic Substances in EPA, has a quote 2 fully fluorinated carbon atom definition. That is its current definition for pesticides. Some states, Maine has taken up a 1 carbon definition. Minnesota has taken up a 1 carbon definition. However, those are not the same. So even within states considering a definition, they're not consistent with EPA's definition with respect to pesticides, but they're not consistent across state lines with how they're interpreting those chemical structures.
I have Delegate Guzoni, followed by Taveras, followed by Kaiser.
Thank you, Madam Chair.
You're welcome.
I'm not sure who's best to answer, so you guys can duke it out. So I have children. So I'm just a little confused. So and certainly could be wrong, but my sense from the first panel was that they're basing their approach off of a list, an EPA list that's used by lots of other folks and organizations of PFAS and matching them to product ingredients on different products. And that I believe they also said that there were similar ones that didn't have the PFAS in them. That's what I heard. So I guess I don't really understand why. It struck me that it seemed like you guys were sort of saying PFAS aren't that dangerous.
No, but
So I'm trying to bring that together a little bit.
Well, what I would say is the simple existence of a carbon fluorine bond, 1 fully fluorinated carbon, does not necessarily is no indicator of toxicity. So we have to be very careful when we're looking at this broad class of chemistry, which does have some substances that are highly toxic. Many of those are off the market, use of PFOA, PFOS. That's a different kind of a thing. If you are looking in EPA's ChemTox database and you run a query on the one fully fluorinated carbon definition, you can get 60 to 100 substances that may come up. That is not consistent with EPA's 2 carbon definition, where you would not have a return of that many substances meeting its regulatory definition. So again, simply defining something by 1 carbon is not an indicator of toxicity. More information needs to be brought into that conversation. And depending on what definition you're using, you may get a different result.
Absolutely. Thank you so much. So the 1 carbon definition, is that also considered a forever chemical?
I would have to say it would depend, but generally not. Different substances have, depending on their chemical structure, they may exhibit the quality of persistence, but they may not. Some things may have no half-life. Others may, again, be some of those very persistent substances that are the root of your question.
Thank you.
Okay, next I have Delegate Taveras, followed by Kaiser.
Hi, how are you? Thank you for coming forward. I'm not gonna lie, I have a couple of questions. Please, if you can give me a little bit of latitude. My first question is, I understand that there are about 14,000 regulated pesticides within the state, and only 66 of them, more or less, contain PFAS. Is that correct?
So there's a difference between a registered active ingredient and a registered pesticide product. So there are approximately 14,000 registered pesticide products, those end-use products in Maryland. And according to the database that was cited by the proponents, about 66 of the active ingredients would fit this definition, and those 66 active ingredients are in thousands of products. Does that make sense? Okay.
Yes. Am I allowed to do a follow? Okay, so what percent of the market share are these pesticides with PFAS?
According to the definition in the bill or the definition of EPA Office of Pesticide Programs?
On the definition on the bill.
I believe if you refer to the letter of information from the Maryland Department of Agriculture, they cite the number of pesticide products that would fit the definition of the bill. I don't know that exact number, nor am I good at quick math, but I can get back to you.
And share it with the committee. And then as of October 31st, 2023, EPA cited PFAS as chemicals of, let me just quote it real quick, as chemicals of special concern under the toxic, and were added to the toxic release inventory, something that I regulated and I enforced, just for full disclosure. So this is the first order of reports are due come July 1st, 2025. So that means to me that PFAS no longer are eligible or for de minimis exception. Is that correct?
Well, first thing, one, pesticides, because they're regulated under a different statute than the Toxic Substances Control Act, are expressly excluded from TSCA. So that does not apply to pesticides because under the Federal Insecticide, Fungicide, and Rodenticide Act, we have a different safety standard to meet, which we have been meeting for 50 years. So with respect to those test orders under TSCA, that is just beginning. In fact, EPA has seconded people from its pesticide regulatory program to get that up and running so that for the chemistry that comprises all the products around us, they're, as you've noted, they're beginning that assessment regime. They're at the very first step. That's what those test orders are. That first wave for pesticides, every single pesticide registered by EPA already has to undergo a thorough risk assessment and receive a determination that it's safe for use within OPP.
Okay. My recollection of my job, we went in, we assessed manufactured, production, or otherwise use of the chemicals. That was 25,000 pounds for manufacture, production, and 10,000 pounds for otherwise use. Okay, so we're talking about a consistent tallying of these reports under EPGRA section 313, correct?
Yes, so
That's
you
different.
you are speaking to the precursor chemicals? Yes, that's where they're regulated as a finished product, but the pesticide is then going through the risk assessment through the Office of Pesticide Programs. So yes, you are correct. Any precursor chemistry is subject to what you've just described. However, that finished pesticide product must then go through an additional regulatory process and a risk assessment.
Okay, I may have more additional questions later, but I'll let it go right now. Thank you.
Okay. Delegate Kaiser.
Thank you, Madam Chair. My question will be shorter. I'm not a trained chemist like the delegate next to me is in fact. I have a question, not for the woman who is doing all the answering just now, but for maybe the two gentlemen to your left and to the woman on the right. I guess any one of you, are you suggesting that PFAS, I don't know the plural for PFAS is, anyway, are you suggesting that PFAS are not harmful? That's a question to someone besides the woman who's been doing the answering to Delegate Taveras' questions.
We're merely suggesting that the regulators, both at the federal and state level, should be allowed to do their job and make determinations based on data.
Opinion on PFAS itself.
No, I want to, again, it's making sure that the regulators that we pay taxpayer dollars to and industry fees to, that they're allowed to do their work.
So maybe I have to ask the question. I'm trying to get a yes or no. Are PFAS safe?
I will try, but
That's
it's
a
not
yes or
going
no
to be
question.
a simple yes or no question because of the multiple definitions that there are for PFAS for different substances. So the wonderful woman who had been doing all of the talking has talked about the difference between the 1 carbon definition, the 2 carbon definition. You have short chain PFAS, you have long chain PFAS, there's PFOA, PFAS. So the answer really is, it depends. I think that we all recognize that there are PFAS substances that when reviewed through the proper regulatory channels have been identified as potentially harmful, right? But unfortunately, it's not a yes or no answer. And so as the gentleman to my right mentioned, we don't feel as though this is something that can be determined through a legislative process with one definition that is inconsistent with the definition that the Office of Pesticide Programs is utilizing at the federal level.
Okay, thank you.
Okay. Delegate Bagnell.
Thank you, Madam Chair. Again, I'm responding to some of what I've heard. There is a federal bill in right now from February 2024 to amend the Toxic Substances Control Act, codify federal cause of action and a type of remedy available for individuals significantly exposed to PFAS, to encourage research and accountability for irresponsible discharge. And I just wanted to circle back to the report that's been referenced because you are correct that the report, the recommendations, the report did not just speak to testing, but the recommendations did. But I just wanted to put on the record some of the other things that are in the report. From MDH, PFAS has been linked to adverse dyslipidemia, metabolic syndrome, impaired immune system responses, liver damage, cancer, neurodevelopmental issues, decreasing bone density, reducing antibody response to vaccines, declines in birth weight. I won't continue, but no studies have been identified to specifically address health impacts in PFAS and pesticides. No studies have been identified that provided exposure models. However, it is expected that PFAS and pesticides enter environmental waters, vegetation, aquatic and terrestrial life and air, and contribute to the overall exposure burden and associated health impacts in humans. That was from the Department of Health. The Department of the Environment also said pesticides containing PFAS compounds have the potential to contaminate soil, surface, and groundwater and air, which could result in impacts to aquatic life and human health from direct exposure or the consumption of drinking water and fish. The human health effects are discussed by MDH above. So I just wanted to clarify that your position is that this report recommends taking no action until we hear from the EPA. Is that correct?
I don't have the report in front of me. I did cite it in my written testimony. At the very end of the report, under the recommendations section, I don't think that it said take no action until EPA does. But I also don't believe that number one, there was a recommended definition cited within that report, which seems to be an issue of controversy. And I also don't believe that the report recommended prohibiting the registration of pesticides that contained PFAS per the report.
Sure. Just to clarify from the report, there are two recommendations from the work group. The first is to follow EPA's lead on the formulation. The EPA is currently developing a method specifically to test various pesticide formulations. The second is to analyze formulations that are registered with the Maryland Department of Agriculture's State Chemist section in order to acquire baseline data. Following EPA's lead would fit into the agency's PFAS roadmap, but would take time. The second recommendation may be the most expedient. Do you believe that this report speaks to the opposition that you have raised in this hearing?
Our preference would be to have the state and federal regulators collect their data, make their determinations for registrations based on the information they're looking at. So we're not aware. I think as of this report, there were 750 CSFs for the confidential statement of formulas that have been reviewed, and they were found not to contain PFAS compounds in the inert ingredient. But they would work with EPA to make determinations on whether to revoke the registration of products. So it's our position is to allow the regulators at the state and federal level to do their jobs.
Thank you. Thank you.
You're welcome. Delegate Riley.
Thank you, Madam Chair. Yeah, so I heard a lot. First of all, thank you to the panel. And thank you for what you do. Thank you for all the wonderful food that you provide for us to eat and keep us healthy. So thank you for all of that. And so I've heard a lot of the testimony for and against, and I think you both agree that pesticides are highly regulated already. Okay.
Yes,
So
ma'am.
they're highly regulated, and farmers have been good stewards over the years on many accounts that, this legislature has passed on you. Thank you for that. But now we see another thing that kind of do you feel like you have a target on your back? Because here's another item that you're basically the person who's just like the pass through. You're using these products, to keep us healthy from the insects and from the diseases and our foods and all of those things. So why do you think they picked your industry to pick on pesticides? Because obviously this product is in a lot of things compared to, that we've heard. Is it just because it's an easy target and they can go after pesticides? But it's kind of crazy to me because it is already highly regulated, and is not the FDA already working on something? So why were you chosen? Do we know that? Did the sponsor mention that to you? Or
Thank you for the question. And I will start by saying I have a great relationship with Delegate Ruth. I respect her very much. We have a very transparent relationship. So I'm not going to speak to what I feel maybe her intent was in putting this bill in. I do trust that that was pure. I also really respect and appreciate your comment that farmers oftentimes are what we like to refer to as passive users of products that may contain PFAS. We had a whole discussion on this last year around biosolids as an example, right? So we as farmers want to know what it is that is in the products that we are utilizing on our farms. I'm also a farmer, around our families, right? And in the food that we eat and the land that we steward. What I think I'm trying to put forth here is that we as farmers feel comfortable that the rigorous regulatory framework at EPA under FIFRA, the Federal Insecticide, Fungicide, Rodenticide Act, is sufficiently protective, because all pesticides must go through a risk assessment process to ensure that they do have not any undue risk or harm to human health, the environment, non-target species, right? And they go through that process on a regular basis to take into account any new science as well. So I'm not saying that we're not concerned about the issue, right? Or that we want to just continue using these products if they do contain PFAS. What I'm saying is that the federal regulatory framework is in place to be sufficiently protective against that risk.
You're welcome, Delegate Hutchinson.
Thank you for the second bite of the apple. I've been hearing a lot about PFAS over the last 2 years. And so as I was just sitting here and Delegate Kaiser asked the yes or no question, and it just sort of made me think, is the term PFAS too broad of a term? And so we immediately go, oh my God, it's bad. And I'll give you an analogy. And if it's similar to this, if I sat here and said, the ceiling here is full of mold and is mold bad, we would all sit here and say, oh my God, we got to get out of here. But then if we put in our penicillin, but if it's on my bread, it's bad. If it's on my cheese, it's bad. But if it's in my blue cheese, it's good. So is that sort of what we're talking about when the term PFAS?
Oh, everyone says all mine, so I'll speak to this. It is a broad class of chemistry, more, depending who you talk to, 15,000 different substances with very different chemical structures. So you're right. Great analogy. I might take that forward about mold, and I'm not making light of the concerns about it. Everyone can agree there are substances in this class of chemistry that need more attention. They're getting that attention under the Toxic Substances Control Act, as was raised by the other delegate. But pesticides are different. We have to go through a thorough risk assessment. Everything has to be known about them. Hundreds of studies have to be submitted. You know, they're very different than other types of chemistry, and we have to have an assessment of safety, and we have to have an assessment that those products, due to occupational exposure as a grower, pest control operator, that over your lifetime of using those products professionally, that you'll be safe. For the rest of us as consumers of food, but also as folks that are subject to, you know, the benefits of mosquito control, et cetera, can the product be used safely if it has a fluorinated molecule? And again, one, I'm not a chemist, I'll rely on that, but simply the presence of a fluorine carbon bond is not an indicator of a PFAS substance necessarily. So it's not a yes or no answer to your point. Again, long chain PFAS, many have been off the market for 20 years in the United States, Canada, Japan, Europe. Other substances, not much is known about them out there in the world of manufacturing, but for pesticides, we have to know everything about that formulated product before it can come out to the grower or to the professional or the consumer. But it's very diverse, and it is not appropriate chemically to consider them as a monolith, as one thing, as an acronym.
That's okay. Okay, I don't see any other questions. You know, we have done a lot of and have looked at a lot of PFAS bill in this committee, right? Because it's the committee of jurisdiction for a lot of the products, right? And I know what is really clear, that it's not a yes or no, but it is with certainty. If you look at the CDC, without taking a position on the bill or not. I know that there's a lot of unfavorable, favorable, you need to work it out, right? That's the reality. But it is not in dispute that they do not break down in the environment, right? That is clear. It's in the CDC. I see you shaking your head. Yes. They can move through soils and contaminate drinking water sources. We know that. That's undisputed. They can build up in fish and wildlife as well, which then people consume. They're found in rivers and lakes and in many types of animals and land. And that, you know, PFAS persist in the environment, and exposure in people can occur by consuming PFAS contaminated water or food, right? We know that there have been some studies that are actually reliable, not in dispute. They have looked at animals, and what they found in animals is that PFAS affect reproduction, thyroid function, the immune system, and injure the liver. There have been some studies that is not disputed in the epidemiologic studies that exposure can cause several health effects. So we know that that's undisputed. So we know that these products, unfortunately, or fortunately, however you want to look at it, help farmers, help us humans with what we do, right? You know, some of the products are used in coating for several products like packaging, clothing, furniture, right? So it's finding that balance that we do in this committee. That is the truth, is undisputed. That being said, I know that even that the federal government is looking at it. I know because the federal government takes a long time, and no offense to my federal representatives, but we do the work at the state level, and it's a lot quicker, which is why a lot of the states are now taking it on. That being said, I know I had asked you to meet with a delegate, and I told you she was an amazing human being, and that she would gladly meet with you. If I can ask you, can you just continue to talk, all right, and see, you know, what comes out of it? That would be great, okay?
Yes, ma'am. I had actually spoken with her before you asked me to, and had the pleasure of showing Delegate Ruth around my farm over the summer. So we'll continue to have those conversations.
That sounds wonderful. And I want to thank all of you, and I know we have more witnesses, just for being patient as we ask the questions. It's not personal at all, but we are very grateful that you're gracious, you know, to just sit there and allow us to ask the questions on both sides, okay? Now, because I want to be balanced, I want to go to the other side now, okay? If I may I please have Brent Walls, and thank you so much. Sean Lynch, Cleo Braber, and I think in person, that's it in person for now. Will you be so kind and call Robin Todd and Stephen Korseski? They are, and Anna Rule, they're the favorable virtual. That would be great. And good afternoon, how are you? Wonderful. Will you be so kind and get us started?
Sure.
Thank you.
Actually, Brent, you want to go?
Sure. Thank you, Chairman, Madam Chairman. My name is Brent Walls, your Upper Potomac Riverkeeper with Potomac Riverkeeper Network. Our mission is to protect the public's right to clean water in the Potomac and Shenandoah rivers. I'm also a farmer, have a horse farm, and so we know the value of making sure that our grass is lush and available for our horses. Removing pesticides with PFAS is a logical path in stopping one of the sources of PFAS that pollute our rivers, land, and families. In 2022, 113 waterkeeper groups sampled 114 waterways in 34 states and DC, where 83% of the waterways tested had significant levels of PFAS. Virginia and Maryland had some of the highest levels of PFAS pollution, with Piscataway Creek in Maryland at the top. Chesapeake Bay Program website notes that 84% of tidal streams that are impaired are polluted mostly by pesticides. Pesticides that include PFAS are applied in agriculture areas, rural areas, and urban areas, and all wash into our streams. PFAS is accumulating in fish species in Maryland streams from discharges from stormwater runoff. MDE recently released one of the largest number of sites with fish consumption advisories for PFAS in the US. In my written testimony, I also included a map that you can look at to find out where those locations are. Fish are much more susceptible to increased levels of PFAS that can be tens of thousands of times higher than EPA recommended limits. Maryland concluded a comprehensive study of PFAS in 15 different fish species at 40 popular locations. 80% of those locations were in rural areas. Essentially, how PFAS and pesticides work is you need to have that PFAS stick on the plants and stick in the areas for as long as possible. And PFAS is a waterproofing agent, and it keeps the water away so it can be persistent. Unfortunately, that's why it's forever. So we would like you, I'm requesting that the committee return a favorable report for HB 1190. Thank you.
You're welcome. Next, please.
Hello. Thank you very much for this opportunity to talk with you today. The two food farmers testifying here today, myself, Cleo Braver from Talbot, and Steve Kraszewski from Queen Anne County, are Maryland farmers who, between us, grow grain, vegetables, meat, poultry, eggs, both conventionally and organically, and we both support House Bill 1190. We know as farmers that there are hundreds of alternatives for the about 1,000 PFAS pesticide products that are registered in Maryland. We know because we use some of them. We do not use PFAS products. HB 1190, we think, is a reasonable step to protect the health of the people who eat our food, the families who live on the land, and just as importantly, probably most importantly, the very farmland on which we grow, which would otherwise be exposed to PFAS contamination from pesticides. Maryland farmers are increasingly becoming aware that in Maine, more than 50 Maine farms, I think 60 at this point, were found to be highly contaminated from toxic PFAS, including an organic dairy farm that fed its cows organic hay that was unknowingly PFAS contaminated. The result, the state of Maine had to establish a $60 million fund to financially assist farms devastated by income loss from PFAS contamination of both their farmland and their farm animals. And Maine is only the first of many states, in fact, all of the states that are going to need to address PFAS contamination of farmland, because these things are happening on the land, whether states act or not. A number of Texas farms, livestock, and water have been PFAS contaminated by a neighboring farm, and they are suing that neighboring farm. The first Michigan farm has been closed down due to PFAS contamination in cattle, land, water, and a single New Mexico farm had to euthanize 3,600 dairy cattle due to groundwater contamination from an adjacent land use. I submit it would be far worse to take the land out of the farmer's toolbox than a single toxic pesticide. We want Maryland farmers and farmland to avoid these horrific outcomes. Thank you.
Thank you. Next, please.
Good afternoon, ladies and gentlemen. Thank you for this opportunity. I'm Sean Lynch. I'm the project director for the Integrated Pest Management, or IPM, in Healthcare Facilities Project, now in its 18th year. The project assists Maryland healthcare facilities reduce pesticide use around healthcare populations which are vulnerable by implementing a prioritized IPM program similar to our 1998 and 99 IPM in schools law. And some pesticides and PFAS are known to cause or exacerbate the very illnesses and issues that patients are being treated for. PFAS pesticides addressed in HB 1190, including fipronil, bifenthrin, and indoxacarb, are being used indoors and outdoors in healthcare facilities with repeated treatments over time. Maryland hospitals and other healthcare facilities should be PFAS-free in Maryland to protect the people that work in, utilize, and visit them. At some time or another, that means every single one of us. There are safer alternatives, as evidenced successfully in some of our Maryland healthcare facilities. And as has been discussed, this bill would still allow 13,000 registered pesticides to be available in the state. So consider this also. Our Maryland State House grounds here have been managed pesticide-free for over a decade now, and it looks beautiful. So please act now to protect Marylanders who are the most vulnerable. And that essentially could mean a family member, and deliver a favorable report on HB 1190. Thank you.
And thank you for your time today, and all of you here. Thank you for your patience as you wait. Are there any calls for this panel? You were that good that there are no questions for you. I'm going to call the virtual witnesses in a minute. Thank you for looking out for them.
Thank you.
Have a great day.
Thank you.
May we please go to the virtual witnesses? Yes, sir. Will you be so kind and unmute yourself?
Hello, this is Robin Todd. Is that me you want to hear from?
We can hear you.
Hi, thank you very much, Chair and committee, for hearing my testimony. My name's Robin Todd. I'm a retired board certified entomologist. I spent 39 years testing and registering insect control products for chemical companies and marketing companies. The need to ban the use of PFAS pesticide has been already spoken to. I will address the concern of the pest control community that will be worried that they will lose essential tools to their pest control toolbox. There are 14,000 or so registered pesticide products in Maryland now. If HB 1190 is passed, it would remove just 1,076 of those, or just 8% of the total, leaving 13,000 pesticide products to choose from. The top 10 PFAS pesticides in 2020 by use volume included the top three insecticides: chlorphenapir, fipronil, and bifenthrin. The major uses for these active ingredients include termites, mosquitoes, and bed bugs. There would be over 100 termite products left after the bill, over 900 mosquito products, over 300 bed bug products. The remaining 7 of the top 10 are 2 fungicides and 5 herbicides. Likewise, there are an array of alternative non-PFAS actives. I'd also like to mention in passing that the EPA definition of PFAS includes a 1 carbon that is fully fluorinated, and that yields 14,000 different PFAS. Thank you for listening to my testimony. I appreciate it.
And thank you for being with us today. We appreciate you. So are there any questions for this witness? Thank you so much, sir. May we have the next witnesses, please? Stephen Kraszewski and Anna Rule. Are they there? They're not? So for the record, excuse me? Are they? They're not there. Yeah, I can't do that, but can he try? Can you tell him to please try to get on? They were waiting for him. That'll be great. How about Anna Rule? Does anyone have her number? Can you tell her to try it? Okay. No, it has to be the witness. No? Okay. So I'm going to give them a little time. You can try to reach them. I'm going to go on to an unfavorable panel. If they're not back by the time I do that, we're going to conclude the hearing, okay? Thank you. We have, can you be so kind and bring the virtual witnesses for unfavorable? It is Manojit Basu, Riley, Titus, and Amanda Hagan. Thank you. And I don't know why they're having issues, because we don't kick anyone out. You get the link, you log in with it. We know you're there because we look at the window, and then you come up. The committee does not kick anyone out, for the record. Oh, it's okay. Thank you. Just want to correct. Mr. Basu.
Thank you. Good afternoon, Madam Chair, Vice Chair, and distinguished members of the Health and Government Operations Committee. Thank you for the opportunity to testify on HB 1190. My name is Dr. Manojit Basu, and I'm the Vice President, Science and Regulatory Policy at CropLife America. CropLife America is the national trade association representing the manufacturers, formulators, and distributors of pesticide products used by farmers here in Maryland and across the United States. I'm also an adjunct professor at Johns Hopkins University, teaching regulatory policy and other courses to graduate and undergraduate students. I hold a PhD and have conducted extensive research in molecular biology and toxicology in academic, government, and industry settings. We respectfully request an unfavorable report on HB 1190 as it is unnecessary with existing federal regulations of pesticide and the requirements set by Maryland Department of Agriculture for the registration of pesticides in Maryland. HB 1190 is not necessary as all pesticides, including those formulated with fluorinated chemistry, must be registered by EPA prior to applying for and receiving state registrations in Maryland. To approve a new pesticide, EPA must determine that when used in accordance with the label, a pesticide will not cause unreasonable adverse effects on the environment and does provide a reasonable certainty of no harm to human health. EPA periodically reviews registered pesticides to ensure they continue to meet these robust safety standards. Pesticides are unique with more scientific data available about them than for any other products available in commerce today. Pesticide risk assessment in the United States is built upon a comprehensive framework that involves rigorous testing protocols and risk assessment methodologies to evaluate the safety of pesticide products before they are approved for use. One key aspect of the robustness of pesticide risk assessment in the U.S. is the extensive data requirement imposed on pesticide manufacturers at the federal as well as state level. These requirements mandate the submission of detailed information on the chemical composition, toxicity, environmental fate, and potential exposure pathways of the pesticide. This data is thoroughly reviewed by regulatory agencies to assess the potential risks associated with the use of the pesticide. Furthermore, US EPA employs sophisticated risk assessment models and tools to evaluate the potential health and environmental impacts of pesticide under various scenarios. These models consider factors such as exposure levels, toxicity endpoints, and environmental fate to estimate risk to human health and ecological systems accurately. Moreover, the US EPA regularly updates its risk assessment methodologies and guidelines to incorporate the latest scientific advancements and addressing emerging concerns, including concerns like PFAS. This adaptive approach ensures that pesticide risk assessments remain robust and reflective of current scientific understanding. With respect to PFAS, EPA has put in place an intra-agency work group to develop and implement a PFAS strategic roadmap. Overall, the combination of stringent data requirements, advanced risk assessment tools, and an adaptive regulatory practice contributes to the robustness of pesticide risk assessment in the United States, enhancing the protection of human health and environment. I would reiterate that HB 1190 is not necessary and would respectfully request an unfavorable report. Thank you once again for the opportunity.
Thank you. Next, please. Ms. Hagan.
Hi.
Good afternoon.
Thank you. Thank you, Madam Chair, and thank you, members of the committee. There was a mention earlier of the effect on flea and tick collars of this legislation, and that's exactly what I'm here to talk about. The Animal Health Institute, I'm Mandy Hagan, Director of State Government Affairs for AHI, the Animal Health Institute. We are the U.S. Trade Association for research-based manufacturers of animal health products, the medicines that keep pets and livestock healthy. Animal health companies work to provide veterinarians, food producers, and pet owners with high quality, effective, and innovative products. This legislation would ban topical flea and tick products and collars with active PFAS ingredients that are regulated as pesticides. While we all know some PFAS chemistries are harmful, the active ingredients in animal health products have gone through the type of rigorous safety testing that other people have already spoken about today, including considering the potential effects on the animal, humans, and the environment before reaching the market. These products are used for prevention and treatment of external parasites, such as fleas, ticks, and mites, that can seriously harm animal health and welfare. These parasites can infect humans and cause disease either directly or by transferring diseases like Lyme disease, especially in at-risk populations such as elderly, children, the immunocompromised, and some of these diseases can be life-threatening. The ability to have pets share our living spaces without fear of disease-causing infestations is the result of the wide availability of these parasiticides. For these reasons, we would ask you not to remove these safe, important products from the market. Thank you, and I'm happy to answer any questions.
Are there any questions for these two witnesses? Seeing none, thank you so much for being with us this afternoon. We really appreciate your testimony. Have a blessed day. We have one more, Riley. Is Riley there? No? So I got up and I asked my staff, were links sent to Anna Rule and Stephen, and they were sent. The links were sent to them. Stephen is here now, but Anna is not, okay? So we're gonna call Stephen. Sir, can you unmute yourself, please? Good afternoon, Mr. Stephen. Will you please unmute yourself? Yes, go ahead.
Can you hear me all right?
Yes.
That's perfect timing. Thank you, Madam Chair, Madam Vice Chair, and the members of the committee for this opportunity to speak today. My name's Stephen Kraszewski, an organic farmer from Queen Anne's County, Maryland. I'm also a father of two as well. Our grain farm, our fifth generation century farm, now nearly 1,000 acres of USDA organic certified farmland on Maryland's Eastern Shore, is a legacy of land stewardship. There's nothing we can do about the PFAS already released onto Maryland farmland, a worrisome new legacy and danger being passed along to the next generation. But now that we are aware, and before we reach the point of PFAS toxicity in soil experienced elsewhere, if you have heard, it would be wise to eliminate this avoidable pesticide contamination source now. It is important to note that no testing is required for this bill, and these products are identified by EPA as having PFAS active ingredients listed on the product labels. Agriculture is the #1 industry in Maryland. #1. We don't think it could continue to be #1 if we lose our soil, our farmland, and our farmers to PFAS contamination. There are hundreds of alternative inputs that the agricultural sector can and do use and rely on that don't contain PFAS chemicals as their active ingredients. All the agricultural products grown in Maryland can be grown without PFAS, as many of us are doing that now. We urge a favorable report on HB 1190 for the sake of our farms, our farmer families, and all Marylanders who depend on us for their food. So thank you for your time, thank you for your attention, and thank you for hearing us farmers out.
And thank you for being with us. We really appreciate it. Are there any questions for this witness? Seeing none, and thank you for being persistent.
Oh,
It pays
appreciate
off.
it. Thank you.
It pays off. And then Miss Anna is not here. And did anyone not get called? All right. Is there anyone waiting to be called? All right. This actually concludes the bill hearing on House Bill 1190. Thank you very much. Have a great day. We're going to move on to House Bill 1396. Delegate Howell, will you please, Howard, will you please bring Lisa Lowe with you? I believe that is your panel, but it says Miss Lisa Lowe will be testifying for Delegate Howard. So come forward. And since you'll be testifying for him because he is not well, why don't you have his time, just no more than 5 minutes?
Okay, so I'm here to present House Bill 1396, Drug and Alcohol Treatment Programs, Discharge of Patients and Referral Services Standards. House Bill 1396 does nothing more than enforce what you guys already passed in 2017, and that was the Recovery Residents Residential Rights Protection Act. I won't, of course, read the whole thing that was passed in 2017, but I'll just highlight some quotes. It generally relates to referrals and to certification of recovery residences, which did happen. It
provides to an individual who has been assessed as in need of ASAM level 3.1 services information on where the individual may receive those services. Additionally, the law requires a higher level of care provider to provide information where the individual may receive those services based on their ASAM assessment. It refers the individual to all the services that the individual would normally receive in that level of care. And the passage of this bill in 2017 made it clear that it is not the responsibility of the lower level of care to find these services, but the higher level of care to refer into them. That's already all been passed. This bill simply fixes the problem by making it perfectly clear what is already implied under COMAR and Chapter 580, and it simply forces the BHA to become involved to a greater extent than it previously has been in enforcing these provisions, and to take on a role of an enforcer by reporting to this legislative body on our state's progress toward these goals. So I'd like for you for a moment to picture the reality of our current Maryland continuum. There are two possible scenarios. One is you enter a good detox 3.5 to 4.0 facility and you stay no more than 30 days and you're effectively discharged to a lower level 3.1 or halfway house, and you continue to recover with wraparound services, mental health, legal services, job training, family reunification, whatever you need, whatever in your assessment and your treatment plan, and you eventually return to a productive member of society and live happily ever after. Scenario 2 is you enter a bad detox facility, same 3.5, 4.0. You stay a week and you're discharged back to the streets, and you go back to living in your abandonment with all of your old friends who are still actively using, or to a homeless shelter with no wraparound services and no recovery support, and where many are actively using just outside the shelter. And we call this scenario a relapse waiting to happen. Clients do not know which door, number 1 or number 2, they're walking into when they voluntarily enter a detox program. Now, we've had opposition on this bill that worries that programs required under this bill would turn residential SUD treatment programs into default housing programs because people would stay longer. Not if you have a good discharge planner. They worry that there would be a delay access to treatment for individuals in need. Not if you have a good discharge planner. Number 3, that, hindered treatment effectiveness would happen by commingling active treatment participants who are ready to be discharged with individuals who've completed, who are just getting into treatment. Not if you have a good discharge planner. People worry, opposition worries that it would exceed a 30-day length of stay by keeping these patients longer, awaiting a discharge. Not if you have a good discharge planner. That the Medicaid general fund expenditures would be increased by an indeterminate but potentially significant amount, making our statewide average length of stay in residential treatment facilities increase beyond the 30 days. Not if you have a good discharge planner. We're the only opposition to this bill from the treatment providers that have weighed in unfavorably on this bill is that it is duplicative, and it is for them. They're complying already with the intent of COMAR and our 2017 bill. We're willing to work with anyone to clarify any language in this bill that seems to give an appearance that this bill adds anything to Comar other than discharge planning that holds the bad players accountable and enforces them to provide good discharge planning. The bad players must learn to do what the good players are already doing. Patients' successful outcomes for recovery should not be determined by whether they are lucky enough to have found a good discharge planner. Good discharge planning should be the requirement. The bad providers are always going to oppose this bill. I'm asking that you vote on the side of the patients and pass this bill forward. Thank you.
Do you have any? Okay. You have
So-
anything to say?
No, I actually, so I'm Robin Bissett. I'm Delegate Howard's Chief of Staff. Obviously, you already said he's out sick today. I was just up here for moral support and to show that it takes two people to replace one Delegate Howard.
Okay, are there any questions? Seeing none, may I ask, why wasn't this bill crossed?
Just because it came late.
Okay,
We weren't sure if we were going to introduce it again because we've done it now 8 years.
but I don't see it crossed. The years prior have not been crossed. Is
It
there a
has
reason?
1 or 2 years, I think it was, and no,
Okay.
mainly because initially we couldn't find somebody, but now I think Klossmeyer would like to cross-file it
Okay,
in the future if we just
Okay.
get to her a little earlier.
okay, yeah, have you had meetings with everyone?
Bill has been going on for 8 years.
This year,
past-
have you had any meetings with
Well,
anyone?
last summer, we brought this bill. You told us to meet with the health department, which we did. And as you may note, the health department is not opposing it. And I also did call the unfavorable treatment providers who said it's duplicative. And I spoke with them, especially, I spoke with Pyramid Healthcare today. I said, can you look at the bill and give us any language that you feel would explain this better than?
Can I stop you for a second? I
Yeah.
don't see a support letter from the health department. I don't have.
They
it in
don't
my
have
file.
they don't have an opposed letter.
Okay, so you say they're not, so what you meant to say is they're not taking a position on the bill.
Correct.
Right, because I've been looking for that position for the last like 10 minutes.
They're not taking a
Okay.
position. And the treatment providers who opposed it, they basically said this is duplicative. And then when the Pyramid Health even said, well, the high quality providers are already providing this care anyway. And I said, could you say that again? Because there will be no change to the high quality providers. And he said he's willing to look at the bill and give any amendments. Another provider, Basil Farrow, I've called him. I know he's a good provider. The good providers don't have a problem with this bill. It's only a bill to enforce and make sure that good discharge is happening. As Comar and the bill that we passed in 1970, 2017, the Recovery Residential Rights Protection Act already puts into place.
Okay, so you know what? This bill is going to subcommittee. Can you make yourself available when it's assigned to subcommittee, please?
Absolutely.
She's not here, but I'm gonna tell her. Make sure you're available, okay? This basically will set some standards for everyone to follow.
There are already standards. We just want them enforced.
Right, but not everyone is doing it. And they're not really standards because you don't have regulations, so you need it in writing. Okay, because if there were standards, you wouldn't be here. So we need regulations from the department that everyone can follow. All right, so I would like this bill. in
Thank you.
subcommittee. Thank you. And Aaron is saying, woo. Okay, let's go to, actually, I think this is it for this bill, correct? That should make Delegate Howard feel a little better. No promises made, though. I don't know what's gonna happen. All right, this actually concludes House Bill 1396, the bill hearing for 1396. Let's go to 790, Delegate Buckle. Is he here? Okay. Oh, okay. Okay, sir. Is it his first time here? Oh. This is not your first time here.
This year.
Yeah, like before last year. All right. So good afternoon. I'm calling House Bill 790, medical cannabis employees in healthcare settings caring for qualifying patients. Delegate Buckle, will you be so kind and get started?
Thank you, Madam Chair. It is Delegate Buckle on House Bill 790. House Bill 790, as you indicated, is a bill that the committee has seen before. It has a fairly simple premise. The premise is that medical cannabis is something that has existed in our state. It is something that has been able to have been prescribed. We now obviously have full-blown recreational cannabis. That's not this. That's not the bill. What this bill would essentially allow is for a designated medical personnel, which is defined through the bill, to provide medical cannabis for healthcare related needs, not for recreational needs, not for personal needs, for healthcare related needs to individuals in places like assisted living facilities, intermediate care facilities for individuals with an intellectual disability, home health agencies, hospice care programs, or related institutions. These individuals who, for the most part, are homebound and don't come out to participate in the other medical cannabis programs have been to a certain extent discriminated against. It's very difficult for them to have providers. They want to use medical cannabis in a regulated way, in a safe way, in an intelligent way, geared toward the medicinal effects of the product for their particular concerns and health needs. And there is a block in the way where individuals who work in these facilities cannot act as the distributors or the prescribers of the cannabis product in the medication form. And so that's all that the bill would do, is it would expressly allow it. I would note that the Department of Health, as they did last year, the Department of Health, I'm sure you see this many times, comes in and says essentially, because our some of these healthcare facilities and some of our healthcare programs that fund the facilities are federally funded, and cannabis is illegal still under federal law, that they are concerned that by doing this, it may somehow risk federal funding to these facilities or to these programs. I would just suggest two things. Number one, everything in life is a risk. I have a risk that I could, fall down the steps when I leave this room and go over the side and snap my neck after the day I've had. That might not be the worst thing that's ever happened to me. But everything is a risk. There's a very, very low risk of that. And I think you, as the healthcare committee, understands that. We've had medical cannabis and now recreational cannabis for many years. Is the FBI coming to the growers and arresting them? They are not. Is the DEA busting the shops where this is sold? They are not. Did any healthcare provider who ever prescribed cannabis under the existing medical provision, have they been denied provider status or reimbursee status from CMS or any other federal agency? To my knowledge, that has never happened. So I think that it's an overblown risk that won't occur. And then secondly, if you really are concerned about it, the way to fix it, fairly straightforward. You put an amendment and a clause in the bill that says if any federal agency or third-party payor ever notifies the Secretary of Health that they are going to cease or modify payments negatively to a Maryland program or a Maryland facility because of this provision of law, the Secretary of Health has the ability to immediately cease or suspend the operation of the law in a fail-safe to protect Maryland to continue getting that funding. So I hope that the committee will consider the bill seriously in the vein in which it is intended, which is to help people. I'm not a huge cannabis supporter. I've said that before. I didn't vote for the recreational referendum. I do think there are people who get positive medicinal effects from it. And when they do it in conjunction with a healthcare provider intelligently and reasonably, they shouldn't have such a hard time having access to it because they happen to be in a home healthcare facility or some type of managed care home situation. And with that, I would conclude my testimony. Mr. Butler is here at the committee's discretion for his testimony.
Okay, go ahead.
Thank you very much, Madam Chair, members of the committee. My name is Brandon Butler with Pinnacle Strategies on behalf of our client, Grow West of Maryland. Grow West MD is a cannabis facility in Cumberland, Maryland. It has over 200 jobs right now. 200 citizens of Allegheny County are going there day in and day out on family sustaining wages. What this bill does, however, is also provides almost an equity of dealing with another vulnerable population. In 2020, the Maryland General Assembly, through Education Article 7-446, allows for public schools to administer cannabis to students who are prescribed this. These are individuals who don't have a medical background, but they are school personnel. So here we have a scenario where another vulnerable population, those who are in assisted living facilities, don't have that equal treatment as we do with school-aged children. And so as as the Maryland Cannabis Administration notes in their testimony, that this bill allows further access to medical cannabis without worrying whether a caregiver that is assigned to a patient, and under the current regulations, only 2 caregivers can be assigned to 1 patient. So the patient then has to worry about whether the caregiver's sick, whether the caregiver's off on vacation, whether they're treating another individual, and so that limits access. And for that reason, we request a favorable consideration of this bill.
Thank you for your testimony today. We appreciate it. I'm going to open it up for questions now. Are there any questions for the delegate and his panel? I see Delegate Johnson.
Thank you, Madam Chair, and thank you for the bill. You know, this committee loves these bills. We did work that out with the school for medical cannabis. And in the interim, we worked it out with the MHA for medical cannabis in the hospital. However, they use the same model as we passed for the schools, because there is that fear of possibly losing federal funding. So is there any reason that you would not follow that model until the feds could get their act together, at least to provide access to the medical cannabis for the time being?
And so, Delegate Johnson, I have to concede, I'm not an expert in that. I voted for, I think that was that Connor's Courage, and I voted for the bill. There was some very compelling testimony. My off recollection is that the way the workaround for this concern about, we're actually administering it in these federal facilities or schools, the workaround was that the product, the medical cannabis product was there, then that the individual could almost self-administer it. If it was an edible or whatever it was, they had access to it within the facility or the hospital room, and they could administer it to them themselves. I'm not so sure that wouldn't be a bad thing, except for one thing. Some of these patients, as elderly individuals or individuals that may be suffering from some level of mental impairment or disability, and a healthcare provider has said to them, hey, you're having symptoms related to something, for why you're there, medical cannabis may help to ease those symptoms. I'm not positive 100%, certainly would like to keep working on that, but I'm not positive 100% that they would have, all of them would have at least the ability to self-administer the product the way that you would say, maybe a child of competency could do it, knowing that it's like taking their medicine, or an individual in a hospital room that's otherwise competent is there for a brief period of time to be treated, they could do it. So that to me would be the only differentiation in the method of delivery.
Yes.
Well, on the bill we passed, the Connor's Courage, they had to designate an X amount of care providers, and they went in to administer. So Same way, they work the same, with the same concept for the MHA. So would that work for these patients for the time being?
I would defer to Mr. Butler and the group that he's worked at to sort of the kinks of it, but it would seem like it might.
Yeah, so under the current regulations, Delegate, each patient receives up to 2 caregivers. And again, that is, and then each caregiver can only have 5 patients. And so the concern is, in these medical facilities, okay, so which one's going to be designated as the caregiver? And there's no backup after those 2. It's not, if Delegate Buckle and I are caregivers, I'm out sick, he's out on vacation, the patient is out on the product or on the prescribed medical cannabis. And so what this bill does is it works to create I don't want to say sidestep, but it is outside of those caregiver provisions. It's something that we've worked with the MCA on to, and that was what they were comfortable with.
Sure.
Not only are you gonna dig a little deeper, but I am about to volunteer your services online to sit down with the delegate and see if you could do your magic. Because Vice Chair Carlos and I were sitting here thinking that model will probably work with something like this. Because we do not want to, even though you say they may not, we do not want to jeopardize those federal funds. We count on them for Medicaid, for all these health, programs that we have, right? We have 1.8 million people on Medicaid in Maryland, over 700,000 of them children. So we don't want to jeopardize and all these other facilities, but we've done it before here. So, it's like you don't get the whole enchilada, but you can get a taste of it, right?
Yes, ma'am.
I like enchiladas.
Yes. And I know California passed a Compassionate Act, which actually allows it for oral medication as well. So there is, a pattern out there. So you can go ahead and keep asking, but I would like you to see if you can help.
Sure,
with the
absolutely.
language.
Yeah, absolutely. Well, we'll just end it there then, and I'll get with the delegate and we'll see maybe.
Yeah, is there a cross on this bill?
There is. Senator McKay has the cross file pending in the Finance Committee.
What's the status?
I have been advised, the whisperings and the musings of behind the scene, nothing formal, that he would anticipate that the Senate Finance Committee may move the bill this week in some form or fashion, but that's,
Okay,
who knows?
all right. So why don't I ask you to get Senator McKay, yourself, and Delegate Johnson, who is really the expert on these type of bills here.
Great. Yeah.
And see what you can do, okay?
That would be great. I
And then
appreciate it and
include
appreciate your
the-
interest, Delegate.
Include the Department of Health as well in it, all right?
Yep.
All right, are there any questions for? Are you coming on with a question? Okay, Delegate Taveras.
Yes, and I'm asking this very respectfully. I'm asking, is this for the use for the medical cannabis what is that? Are they going to be exposed to smoke, or are we talking edibles or?
Right. No, I don't think that there would be, in fact, I'm positive that there would not be any smoking in any type of these facilities under the Indoor Clean Air Act, and also a wide variety of medical procedures. This would be edible, I always get the word wrong, tinctures, those kind of things that would be administered not as smoked cannabis flower at all. Yes, no, that's, there wouldn't be any of that in these types of facilities. Any of that would be allowed or would be advisable.
Okay, I don't see any other questions, and if you could do that, that would be great.
We will.
Do it
We'll certainly
yesterday.
pull everyone together and reach out to Delegate Johnson's office post haste.
All right, beautiful. Thank
Great.
you so much.
Thank you very much, Madam
Thank
Chair.
you for your testimony on House Bill 790. This actually concludes the bill hearing on 790, and we're gonna go committee so that you know, to House Bill 65, Delegate Miller. And Delegate Miller, will you be so kind? I believe you have Susie Scott with you. That would be great. How are you this afternoon?
Doing well. How are you guys?
Doing well.
Thank you.
Getting through things. You can get started. Thank you.
Good afternoon, Madam Chair, Madam Vice Chair, and esteemed members of the Health and Government Operations Committee. For the record, I am Delegate April Miller, and I would like to thank the committee for the opportunity to present House Bill 65, which will require any provider of healthcare on a school campus or on a school-based health center to provide parent or guardian notification of consultation, diagnosis, and treatment of their minor child at school. I want to speak for a moment about why this bill is necessary. Wraparound services are a cornerstone of the blueprint. We have more and more community schools with school-based health clinics and are finding ways to increase students' access to care, including telehealth, mental health, dental care, and vision care. This unprecedented merging of healthcare and education will create some challenges to best practices regarding consent to treat, HIPAA compliance, as well as to keeping parents involved in healthcare decisions that impact their child. Whether we are talking about issues like childhood obesity or increasing numbers of eating disorders, addictions to social media or video games, healthcare, immunizations, vision or dental exams, or even a strep throat diagnosis, on and on, parents or guardians absolutely need to give consent and be involved for best outcomes. I spent some time over the interim with different school-based health centers and providers, talking to them not just about their practices, but about their philosophy on consent to treat minors and parental involvement. I am impressed in some areas of the state where we have merged the school-based health with an existing local healthcare network and a local pediatric healthcare provider that already have a presence in their community. There are many local best practices currently in use that are a medical model for other systems to follow and designed to include parents, not find ways to exclude them. I am more worried when the school system oversteps into healthcare, when telehealth is provided at school or with a non-physician run school-based health center. I have concerns if a consent to treat form is sent home at the start of the school year and used by the health center as a blanket consent to treat, and no other health information would be provided to parents about a visit to a health center or when treatment is provided. Now I want to address what this bill, as amended, does not do. It does not put students at increased risk of harm. I requested, and you should have, an amendment that clearly states that this bill does not authorize or condone parents or guardians to engage in conduct to ever abuse or neglect their child, period. There are mandated reporting laws that schools and healthcare providers must follow that would not be superseded. I also added that when a healthcare provider believes the disclosure will lead to harm to a minor, notification would not be required. However, except in those narrow circumstances, parent notification would apply. We recently passed a telehealth at schools bill on the House floor. Think about what this may mean without notification. A 12-year-old in Maryland, who we all agree does have limited health literacy and may not even fully understand health privacy yet, we said we would allow them to have a telehealth therapy appointment in school. We did not make sure in the legislation that they would have privacy. There could be a teacher or staff member in the room. There very well could be an outside group that sets up and provides a telehealth appointment at no charge. And that student may not have the strength, maturity, or capacity to advocate for themselves or for the basic need of privacy. So even the best provider may not realize someone is actually in the room with the child. There could be a situation where a coach or teacher is sexually abusing a child and sets them up for an appointment for an STI evaluation. 16-year-olds can be put on medications that have devastating side effects or put them at increased risk of suicide. Let's talk about who is responsible if information is withheld from parents on risk of medication, or if their child is at high risk of harming themselves. And if a child does commit suicide, who's responsible? When the very people closest to them were not given information that could have saved their child. And what if they were allergic to the medication? Or who actually is the best historian of a child's health history, the parent or the child? And who is responsible for protecting a child that was abused at school and treated at school, and parents were not notified of the treatment? Parents matter. By every metric, involved healthy parents are the biggest indicators of success for their children, academically, socially, emotionally, with better health outcomes, and even in avoiding unhealthy and risky behaviors. A notification to parents gives them the information they need to monitor their child's health and well-being. And I ask for a favorable report on House Bill 65. Thank you, Madam Chair and committee.
And thank you for being here. What's next?
Good afternoon, Madam Chair, Madam Vice Chair, and members of the Health and Government Operations Committee. My name is Susie Scott, and I'm the Chair of Moms for Liberty Maryland's Legislative Committee. We request a favorable report for House Bill 65. Research shows that parents' involvement in their child's mental health therapy is linked with better outcomes. Kids do better in therapy when their parents are actively participating. All medical interventions come with risks, mental health interventions included. The medical term is iatrogenesis. It literally means originating from the healer and refers to the healer harming the patient in the course of treatment. This happens not because medical practitioners are malicious, but because all treatment exposes the patient to exogenous risks. As we're turning our schools into health clinics and assuming that every child is on the first tier of the multi-tiered systems of supports and in need of intervention, we're creating an even greater mental health crisis in our youth. What can we expect if you take a whole generation of children and expose them to unnecessary mental health treatments in the school setting without parental knowledge or involvement? Unprecedented iatrogenic effects. It's one thing to treat children who have suffered a truly traumatic event with mental health counseling, but the trauma-informed care and trauma-informed education model that is now in vogue is predicated on the notion that all children are in need of therapy. But not informing parents about mental health counseling, schools are inserting themselves between the parent and the child. This is in direct conflict with the parent's fundamental and constitutionally protected rights to direct the upbringing of their child. These rights extend to the parent's right to direct the medical care of their child. By failing to inform or include parents in mental health therapy, schools risk alienating suffering children from those who know and love them best. Parents should never be excluded from knowledge and care that impacts their fundamental right to exercise the primary role in their child's well-being. Moms for Liberty Maryland Legislative Committee urges a favorable report for House Bill 65. Thank you so much.
Thank you. I'm going to open it up for questions now to the committee. Delegate Shalega.
Thank you, Madam Chair. Welcome to our committee, Delegate Miller.
Thank you.
So, while I would agree with you that parents need, as I've always told my children, there's no one that loves you more than your parents when they were children. And, but I see that there's a lot of testimony in favor of your bill, Delegate Miller, mostly from parents, but I'm seeing some unfavorable from the teachers union and some others like that. Why do you think they're opposed to that?
Well, and I hope, I understand some of the opposition in the way the original bill is drafted, but I hope I addressed a lot of the concerns. And if they had seen the amended version in response to a lot of the concerns that were brought forward, I submitted amendments to address the issues, and I feel like the amendments would speak to the opposition, and I would hope that they would either withdraw or any kind of unfavorable opinion. That. Mm-hmm.
Thank you, Delegate Shalega. Any other questions from the committee? Seeing none, thank you so much for your testimony today.
Thank you.
Appreciate it.
Thank you, Madam Chair. I do have a voting session, so if I don't stay for the whole rest.
Thank
Okay.
you for letting me know.
Of course.
You have a blessed day.
Thank you, you too.
Thank you. We have next, if I may, there is a Kinsey Funk, Jeremy Browning, Lee Blinder. Will you be so kind and come up? And this is a panel of unfavorable. Good afternoon.
Hello, good afternoon.
Will you please get started?
Yes.
Thank you very much.
Thank you, Madam Chair and members of the Health and Government Operations Committee. My name is Kenzie Funk, and I'm here on behalf of Strong Schools Maryland as a policy associate in strong opposition of House Bill 65. Strong Schools Maryland is a network of education advocates dedicating to transforming the Maryland public school system through the blueprint for Maryland's future. House Bill 65 mandates that any school based healthcare provider shall provide to a student's parent or guardian information about any consultation, diagnosis, or treatment. To put it simply, not only does this piece of proposed legislation impose barriers to healthcare access for students, it also undermines existing Maryland state laws and actively puts students' lives and well-being at risk in the name of parental rights. Under current legislation, the state of Maryland acknowledges the rights of minors as young as 12 years old to consent to confidential mental health treatment for mental health issues. We must ask ourselves why this current legislation was passed. That involves confronting the hard truth that some people put in positions of power over children, including parents and guardians, do not always have the best interests of the child at heart, especially concerning personal information that could be shared while seeking mental health treatment. For example, the True Colors Fund notes that family conflict is the most common cause of all youth homelessness. To illustrate, 50% of all teens get a negative reaction from their parents for coming out, and 1 in 4 teens are forced to leave home once they come out. Further, protecting a child's right to privacy has been proven as best practice in school-based healthcare. According to the NIH, it is considered a human right and evidence-based component of care. Furthermore, adolescents are more likely to access care and more likely to be truthful in how they seek help when their right to privacy is protected. The Maryland General Assembly, as the governing body, has the power to affirm and protect these rights and has a moral imperative to do so. The risk of undermining our students' right to privacy is too great to too many populations for this bill to pass, even with the amendments. For these reasons, we respectfully urge an unfavorable report on House Bill 65. Thank you.
Thank you very much. Next, please.
Good afternoon, Chair Pena-Melnick, Vice Chair Cullison, and members of the Health and Government Operations Committee. For the record, my name is Jeremy Browning. I use he, him pronouns, and I'm the Director of the Maryland Commission on LGBTQIA+ affairs. I also want to mention that many of the commissioners are parents or even grandparents. The commission is in strong opposition to House Bill 65. While the intent of ensuring parental involvement in a child's medical and psychological care is understandable, the commission is deeply concerned that the provisions of this bill risk the safety, well-being, and rights of LGBTQIA+ students. For many queer and trans youth, schools are places where they can seek affirming support for their mental and emotional health. This bill would require healthcare providers to out LGBTQIA+ students to their parents without their consent, potentially jeopardizing the mental health and physical safety of queer and trans youth whose parents may not be accepting of their gender identity or sexual orientation. The ACLU explains that children and adults have constitutional right to not have intimate facts about their lives disclosed without their consent. Forced outing bills like this bill are designed to do exactly that, reveal private information about queer and trans students regardless of whether the student consents or whether they may suffer negative or harmful consequences at school or at home from that disclosure. Forced outing bills harm students, educators, and the systems purposely put in place to support the mental health of youth. Simply put, bills such as these hurt kids, especially those that may be transgender, non-binary, queer, or questioning their gender identity or sexual orientation. As a result of the severe risk of harm posed by the possible passage of House Bill 65, the commission urges an unfavorable report. Thank you.
Thank you very much. Next, please.
Greetings, Chair Pena-Melnick, Vice Chair Cullison, and the esteemed committee. My name is Lee Blinder. I use they, them pronouns, and I'm a very proud transgender public school graduate from Maryland. I'm also the executive director of Trans Maryland, and I am the chair of the Maryland Commission on LGBTQI+ affairs. My testimony today is my capacity with Trans Maryland. Trans Maryland represents thousands of transgender Marylanders, including transgender youth who are rejected by their families and forced onto the streets. We regularly receive calls to house these newly homeless children safely. We strongly urge the committee to vote against House Bill 65 in all of its forms and any similar forced outing bill that may be introduced. A recent survey of peer-reviewed scientific studies by the World Professional Association of Transgender Health, also known as WPATH, demonstrates hundreds of studies culminating in several recommendations, including that parents and caregivers and healthcare professionals respond supportively to children who desire to be acknowledged as the gender that matches their internal sense of gender identity. According to WPATH, transgender children experience psychological difficulties because of gender diversity-related rejection. whereas children whose gender identities are accepted are well adjusted. Forced outing provisions are contrary to providers' professional responsibility obligations to protect a student's confidentiality. Transgender students who feel safe sharing their gender identity with their families will do so, and they are not at issue in this law. Transgender children face a demonstrable risk of rejection and abuse because of their gender identity, which results in transgender youth being overrepresented in homeless shelters and foster care homes. If enacted, House Bill 65 would escalate this issue in Maryland and for all the transgender Marylanders we serve. Transgender Marylanders deserve to protect our identities as we see fit. We ask that you oppose House Bill 65 in all of its forms. Thank you.
Thank you for being here with us. We're going to go online. Sandy Rains, please unmute yourself and provide your testimony. Please unmute yourself.
Okay, hi, thank you. Honorable Chair, members of the committee, thank you for this opportunity for allowing me to testify on House Bill 65, and I urge you to give it an unfavorable report. My name is Sandy Gold Rains. I use she, her pronouns, and I'm a resident of Baltimore County, member of the PFAG Howard County chapter, and on the board of GLSEN Maryland. GLSEN Maryland has submitted written testimony that lays out the position and supporting facts determining that the intent of this bill that requires schools to inform parents of any medical or mental health care they receive at school compromises the emotional and physical safety of students, especially for LGBTQ+ students. This bill and others appears to be another attempt to circumvent the ruling by a federal court judge that ruled in favor of the Montgomery County Public Schools policy that allows students to not disclose to the parents their gender identity or sexual preference if they believe they are not safe at home. The judge said in his ruling, the guidelines carefully balance the interests of both the parents and students, encouraging parental input when the student consents, but avoiding it when the student expresses concern that parents would not be supportive or that disclosing their gender identity to their parents may put them in harm's way, unquote. Sadly, too many LGBTQ+ youth have families that are not supportive. GLSEN School Climate Survey finds that less than 40% believe their families are supportive. And the Center for American Progress reports that just about half experience negative reactions when they come out as gay or trans. This leads to increased risk of emotional and physical harm that results in increased risk of homelessness that then leads to increased risk of drug use, sex work, and suicide. The Trevor Project reports that 40% of LGBTQ youth reported sleeping in a place other than their home due to being kicked out, abandoned, rejected, or having conflicts at home. Again, I urge you to please give an unfavorable report, and thank you for allowing me to testify.
Thank you for being with us today, and everyone that's still waiting for your bills to be called. Thank you for being patient. We'll get to it. I'm going to open it up for questions now. Delegate Lewis, followed by Vice Chair Collison.
Thank you, Madam Chair. Thank you to all the panelists. I think it's great that the LGBTQ Commission is now up and running and giving us good feedback and guidance on policy. My question is for Lee, and I'm curious because I know a lot of Marylanders who have kids love their kids and accept them and support them. But I realize that not all families are accepting and welcoming of all, and so how would you answer the concern that parents know best when it comes to a child or, an adult child or a person in their family that whom they don't understand, reject, and try to harm? How do you respond to that?
I really appreciate your question, Delegate. So, when we're thinking about children, we all really want our children to be safe. And we want our children to have excellent relationships with their family. We want folks to be supportive, to stay in their homes. It makes my job a lot easier when parents and families and guardians have affirming relationships with their children. It's always really difficult when we have to house a child who's been thrown out of the house. It's just frankly very difficult to do so. Not everybody has the space and the time and the intentionality to take in a child who is in a situation of trauma, of experiencing that rejection that kind of hits down to that really core place where people, find a difficult time to come back from. So, to answer your question on, what do I tell folks that parents should ideally be those places? I think we need more education for parents so that they can better understand why sexual orientation, gender identity, sexual characteristics for intersex people, why those things are so important and inherent parts of who people are, why they're not changeable, why they are very common, and why they're not just suddenly new. They've existed since the beginning of time. So that education piece is really important so that, children can stay with their parents and ideally, are having those conversations and disclosing this information, to their families and then staying in their homes in a loving and supported way.
You're welcome. Vice Chair Collison.
Thank you, Madam Chair. So first of all, thank you all for being here. And you know that I'm extremely sensitive to the LGBTQ issues and understand them completely and know that's, why what this bill could do, to harm children of LGBTQ or questioning kids. So, but I am going to relate a little experience I had back when I was working on a bill to decrease the age to 13, where youngsters could get psychological help without permission. And a member of this committee who might not, we had a number of young people testify, and a member of this committee uncharacteristically came to me after the hearing saying how surprised they were at the hearing. This person said, "I love my children. I will do anything for my children. But I learned today that not every parent feels that way." So I'm wondering if you all could speak to other experiences that children might have that would make it difficult for them if their parents were involved in, were seeking help at the school and needed that kind of confidentiality.
I think first of all, thank you so much for your question, and we appreciate all your work for the LGBTQ plus community. I think that there's lots of other communities that could be impacted by the passing of this legislation. For example, STDs, STIs, sexual health history, pregnancy history, all those things can be somewhat detrimental if they were to be shared without the consent of the student to the parent and might result in homelessness for said student. Furthermore, mental health treatment in general outside of LGBTQ specific issues is stigmatized in many families. Many families would maybe judge their hypothetical child for even seeking treatment. So while we come from the perspective of advocating for LGBTQ youth, this bill will impact a plethora of other groups, which is why it's so important to consider the risks of passing this legislation.
Yes.
If I may add, there's another group, and that's those students who are bystanders to other bullying and abusive behaviors that other students face because of their gender identity, sexuality, or at home, where they might be facing at home. And the student who is the bystander and witnessing and support to that student may be seeking healthcare. And by reporting to families, it might be causing harm to the other student and the other family.
Thank you very much. All right, thank you. It's okay. Anyone else? It's okay. Delegate Hutchinson, it's all right.
Thank you, Madam Chair. But first of all, you did see the amendments. You correct us. Okay, that's not really my question. So I've shared this with others in this committee. So my daughter identifies as queer. She has incredibly loving parents who are divorced. And she knew and could come home and talk to us and share her feelings with us and knew that she would always be loved, never hurt, never any retaliation, never any issues, everything but love. But when I think about this bill and I say, but what if she was fearful of coming home and talking to her mother and father about this? And she did something harmful to herself because she wasn't sure where she is. And I hear a lot about suicide being, prevalent when situations like this occur. And I would really have to sit back and say, if the school knew and I didn't know, I would be devastated. I'd be angry. How do you respond to that?
So in schools, specific employees are mandatory reporters when it comes to suicidal ideation and when students pose a threat to themselves or others within their community. So in cases such as that, mandatory reporting. However, we feel that the passing of this legislation basically opens up a slippery slope into violating a student's right to privacy. So regardless of how maybe your specific family would react, and I'm really happy that that's the response that you would give your child, and that's extremely validating and accepting. But unfortunately, many Maryland students are not in the same position and don't have the privilege of being able to come home to their families. So just to pose the hypothetical opposite situation, what if there was mandatory reporting and a student did have a family that stigmatized LGBTQ, queerness, etc.? They told the family and then the student harm themselves. So if we talk about hypotheticals, we could go in a bunch of different directions, but overall, I think we should prioritize the safety of the student themselves.
Sure.
But this isn't, as I read the amendment, it wasn't mandatory. So if the school knew that the child wouldn't be in harm, which the school would certainly know that my daughter's mother and father would accept her lovingly, I would want them to tell me and know that. So this amendment seems like it changes that to make it possible for us to know by the school.
Am I allowed to respond to this? Or is that a question?
Yes, you can.
Okay, cool, thank you. So that's a great point. What I would say to that is, and thank you for your question and for kind of bringing this conversation forward. What I would say to that is that while the amendment does take into account some of the concerns that we had regarding the legislation, we feel that in general, speaking to the rights to privacy that students have, that we should prioritize not supporting this legislation in of itself, because we believe it's inherently could cause potential harm to students, regardless of if it's the judge of the school of whether, or the child themselves of if it's safe to tell them or not. Because at the end of the day, we don't know if the school system is the ultimate judge of character of whether or not a child has a safe space to come home to and share that information. So it's also dangerous to put that power in the school's hands. So that's why we believe that striking this proposed legislation in general would be the preferred response.
Okay. Seeing no other questions, thank you very much for being with us today and for being patient as we asked you questions. I am going to now move on to a panel of favorable, Jill Capper. Is she online? Not online? All right. So Ms. Capper is not online. We just checked. All right, let's go to another unfavorable. Oh, no, we have it already. We're done. Did anyone not get called on this bill, either favorable or unfavorable? All right, this concludes the bill hearing on House Bill 65. Thank you for your patience as we move through these bills. And we have next. I had to do a little bit of moving things around here because there's some people that are not here for the bills, but oh, he did make it?
Yeah.
Oh, I moved you. I moved you and I made the announcement. So we got a message from your office to move it. So I apologize. Yeah, Yeah, hold on a second. Let me just call, is Delegate Kurt, are you ready for your bill? All right, let me just call a couple of very short 1 or 2 witnesses, okay? See, we were trying to be accommodating to you, Delegate Cardin. Delegate Cardin and I have met how many times, Delegate Cardin, on your bill? Go ahead, Delegate Kern.
It will take me longer to read the bill title than to give my testimony today.
That's what I thought.
Good afternoon, Madam Chair. I'm Delegate Ken Kerr. I'm here to present House Bill 1476. State Board for Audiologists, Hearing Aid Dispensers, Speech Language Pathologists, and Music Therapists Appointment of Members. This bill makes a change in the manner in which a member is appointed to the board by specifying the governor must appoint the audiologist members of the board with the help of the Secretary of Health from a list submitted by the Maryland Academy of Audiology rather than a name submitted by the board. That's the end of my testimony.
All right. Are there any questions for the delegate? Seeing none, oh, you have a question? Oh.
Thank you,
Go
Madam
ahead.
Chair. Delegate, so you're saying the audiologist will nominate the board member, but only the audiologist? What about all those other folks that are overseen by that board?
There are a couple of them that already do it this way. The music therapists and the hearing aid people, they already submit the name directly to the governor rather than through the board. The audiologists are asking for the same opportunity to select their own representatives.
Audiologist, that authority. I'm just worrying about my speech language pathologist. So.
Okay, and you might want to know that it just passed the Senate, clean bill, no amendments.
Okay, thank you.
Thank you, Madam Chair.
Any other questions for Delegate Kerr? Seeing none, that concludes the bill hearing on House Bill 1476. All right, yes, Delegate Collison, you say yours is quick too, right? All right, let's do it. Is there a Sarah Sample here? How about a Laura Howell? I know she was here earlier. I don't see them. All right. You're it, Delegate Collison. You're enough. Let's do it.
Not very often that I'm here by myself, Madam Chair. But thank you very much. For the record, I'm Bonnie Colson, here to present House Bill 1475. Thank you for the opportunity to present this bill on behalf of it began as a representation of Montgomery County, but we believe that this is a program that or a possibility that can work for other counties. And it really addresses the fact that our Office of Healthcare Quality is overextended and is not always able to complete the annual inspections that are required. And in order to make sure that the residents in those facilities are safe, that they have the appropriate staffing ratios, and that the facilities are adequate. Prior to about 5 years ago, Montgomery County had permission of OHCQ to do its own inspections of its 34 nursing homes. And that went on for a number of years. And those nursing homes were inspected, if not every year, at least every other year. And then, actually it was in 20, the memorandum of understanding ended with the OHCQ, and they have not been able to reestablish the authority to do those inspections. So what this bill does, as it is amended from the Senate, and we are going to make this bill look exactly like the Senate bill, is say that any local government, so it would have to be a local government, a county or city government, who requests the authority to do the inspections of the nursing homes, only nursing homes in its purview, that they would be allowed to do that under an MOU, an agreement with the Department of Health. And just to give you an idea of, you know, the reason this bill came to us and the reason that our local Commission on Aging came to my senator and I and said, you know, in 2019, when they had the authority to do it, there were 10 inspections. In 2020, there were 13 inspections, and that was only up until July, because in July, the memorandum of understanding. Since then, since 2021, only one inspection of a nursing home in Montgomery County has been done. And again, I'm not pointing fingers. I'm just saying there is an overextension in OHCQ. I will tell you that we are working with the Department of Health, and we are getting our Commission on Aging and Department on Aging from Montgomery County and the Department of Health and the State Department of Health together to see if we can resolve this locally. But we haven't gotten quite there yet. So I wanted to bring the bill here and for your consideration, and I humbly ask for a favorable report. And if there are questions, Madam Chair, I'm here.
I have one, but Delegate Shalega's first.
Okay.
Thanks, Madam Chair. I'm shocked, Delegate Collison, and I see two questions, quick ones. The Department of Health says they can't do it. So what are we going to do to fix that? And number two, are there private companies that can do this? And maybe there's a need. If all the counties are having and jurisdictions are having trouble getting their nursing homes inspected, this could be a great opportunity if they exist for a private inspection company.
Well, I'm not sure about the private inspection companies, but I'm sure inspectors were, in fact, in Montgomery County, we had a team of inspectors that did exactly that. That was their only job. And they were hired to do it. There was some state subsidy. It wasn't completely funded by the state. But you know, the county was contributing to it as well. The question about whether or not they can do it is an absolutely legitimate one. But you know, the question is, why could we do it for many years and then not be able to do it? But now we are looking into the authority from CMS, because since OHCQ is the delegated authority to inspect nursing homes, then CMS expects that the OHCQ is doing them. So, you know, whether or not there's a way, and that's what we're working on now, to see if there's a way for OHCQ to delegate some of that authority under some kind of supervisory model from OHCQ, just to make sure that it can get done. So we're working on it, but we felt it's an issue that we really need to address. Yeah.
All right, Delegate Lewis.
Thank you, Madam Chair. Thank you, Delegate Collison, for Madam Vice Chair for this bill. Very much needed. I was looking over the witness testimony, and there's a letter of favorable with amendment from the Developmental Disabilities Coalition. They're concerned that now that institutions overseen by them, or you know, under the purview of the DDA licensed institutions are now fall under this bill, they wonder if they can be excluded. And I wonder what you thought about that.
When the bill came in, it was way too broad. And it has been amended to say only nursing homes. Yeah, then so we accepted that as a friendly amendment. Thank you.
Okay. Shalega again? All
Sorry
right.
for the second
Go ahead.
bite, but I have to tell you what Dr. Google said.
Uh-oh.
Maryland has nation's worst nursing home inspection delay, February of 2023. So if Dr. Google's right, we have a bigger problem than we thought. Thank you.
Hold on a second. Hold on. No, let me just.
I'll have, if that's is it so, it's what Dr. Gould says, so.
All right, so on this bill, Delegate Collison, and this is not directed at you. I know I have it on good authority that the Department of Health have been trying to meet with Montgomery County. They sent communication on February 5th, February 2nd, February 5th, February 20, February 21st, February 27, and March the 4th. And Montgomery County has refused to have a meeting with the secretary. I have it on very good authority that that meeting is taking place right now as you and I are right here in this committee. Okay, so.
Thank you for that.
You're welcome. So that being said, let's see what happens, okay?
Okay.
Seeing no other questions, thank you, Delegate Collison. This concludes the bill hearing on House Bill 1475. We are gonna call, because Delegate Cardin, this bill, House Bill 1100, is jointly assigned with Judiciary, and we have the members of Judiciary here. Will you please introduce yourself?
Delegate Kim Taylor.
And Delegate Karen Simpson. So Delegate Kim Taylor and Delegate Karen Simpson are here with us. One second, and they'll be joining us. So Delegate Cardin, why don't you, who's your panel?
I'd like to bring up
I believe you have
Ricardo,
Stephanie.
Dan Shattuck, Stephanie Wolf, and Meg. What? Go ahead, come on up.
Yeah, they're meeting. Yeah. And if you will be so kind, all of you, if there aren't enough chairs, just pull up a chair, please. On either side, you can pull up a chair. Is the young lady testifying as well?
Eventually.
Okay, you can pull up a chair on the other side, please.
Thank you very
Wait,
much.
why don't you get started?
Madam Chair, members of the committee, John Cardin, on behalf of House Bill 1100, asking for your favorable report. We just spent an hour debating the governor's housing package in Judiciary, which was jointly assigned. So thank you from members of my committee to come up here as well. This is a really has become a very important issue in my heart. And I think you're going to hear some testimony from the folks opposing the bill and the folks with me who are in favor of this bill, that what we are dealing with here, and you hear this every day, we're dealing with the most vulnerable of our children. These are the young children who have been abused, who've suffered trauma, and who have been asked by the state to be taken care of by child advocacy centers. And I'm just gonna say from the outset, all the child advocacy centers have come out opposed to this legislation, or affiliates of theirs. And I find it suspicious because what we're asking for in this legislation is very simple, and according to everybody, are things and information that is already being provided, but we just want to make sure it's being provided to the state. So the fact of the matter is that child advocacy centers are public institutions that receive money to treat children and families that have suffered, as I said, abuse or other trauma. And there is no state oversight on them. Now, you will hear from the opponents that there is state oversight. But every time we turn and look to the oversight, what we find is that there's a National Accreditation Association, which has the only and only policing authority over these institutions or these organizations. If you file a complaint, where do you file it? There is no where to file a complaint. It can't happen. The National Alliance has already indicated, and you'll see testimony in your folders, that if a complaint is filed with their National Accrediting Association, they indicate that they don't have the authority or the ability to be able to do anything if there are any violations. So what this bill does is it asks for a reporting from these associations to the Department of Health, and it allows, if there's allows for investigations, and if there's an investigation and found that there's a violation of the standard of care, that there can be a civil fine for that. I'm going to just mention, I put out all the testimony opposed to this bill says this essentially the same thing. We already have an accreditation. We already have oversight. We don't need this. Why are you making us do this? And I find that very curious. I'm just going to pull out the Maryland Hospital Association's testimony, which if you read like this first paragraph, it says what they do, that they do forensic nurse examiners who receive special training and evidence to deliver trauma-informed care to survivors of violence and abuse, to these young children who can oftentimes be suicidal or self-harm or harm others, and they need to make sure they're being cared for. And then they say that House Bill 1100 would create a new definition for child advocacy centers, which is absolutely incorrect. The definition of child advocacy centers is taken directly out of the Health General Code. So I'm hoping that while I'm talking and pontificating, I'm giving you an opportunity to read some of the testimony. In your testimony, you will see that there are some anonymous pieces from parents whose children were being cared for at these child advocacy centers. There's also a letter from Stephanie Olarte, thank you, Olarte, who indicates at the very end of her testimony, it's not very long, it's only a page long. She says, these families currently abstaining from providing their names and testimonies, it's often due to fear they have because they're worried that their stories are going to be retaliated, they're going to be retaliated against. So, and then there's also a standard of, an ethical standard of care of the psychologists, psychiatrists, and other healthcare practitioners in that they can't ask for these individuals who might have been mistreated or improperly dealt with to be able to come here. They have an ethical obligation not to solicit that kind of assistance. So who you're going to hear from are the psychologists who had to deal with this. I'm going to end with this, Madam Chair. I've already gone on long enough, I know. There was a situation in Montgomery County where there were five whistleblowers on fiscal, financial, and administrative issues, not on anything having to do with providing care to their patients. They were then relieved of their services. These were practitioners. These were psychologists or social workers or other healthcare practitioners. They are now under an ethical obligation to tell their at-risk students, children, that they will not be getting a call from them the next day to see how they're doing. These are, again, children who are potentially suicidal or other problems. And they have an ethical obligation to say, I've been let go. You're not going to hear from me. They have spent the last 6 months creating the first trusted relationship that these children have had in their lifetimes. And now they need to call them to say, we're not going to be able to treat you anymore, which is not the big deal. Okay, so be it. But their former employer that let them go said, you're not permitted to reach out to them. So now they have two different issues. They have an ethical obligation to communicate, and they have an employment obligation not to communicate. And what do? So they chose not to because they were afraid of retaliation and fear of litigation. So they didn't. And what happened is for 3 weeks or so, these children are expecting a call every single day, didn't get a call. Now, I know that there's probably people shaking their heads behind me saying that didn't happen or whatever. And if there's any litigation going on, they can't admit any wrong, and that's fine. I don't care about what happened in the past. I want this in the future. I want to make sure that our children have a continuity of care policy in these child advocacy centers or in the organizations that are contracted by the child advocacy centers to make sure that if this situation happens, that these children are not left alone even for a day. So that's the story. I hope you have an opportunity. There's a tremendous amount of testimony, both in favor and opposed. I would ask you to review it. I think it's very informative, and I look forward to any questions you have. And thank you, Madam Chair.
Okay, who is next, please?
I am, Madam Chair.
Give us your testimony.
Good afternoon. Thank you for the opportunity to speak today. My name is Dr. Stephanie Wolf, and I am a child trauma psychologist here in Maryland. I'm the chair of the Maryland Psychological Association Legislative Committee, and I'm here to testify with strong support for HB 1100. I love CACs. I've worked at a CAC for many years in the past, and I'm currently working closely with CACs now, even collaborating closely with one locally to create a state-of-the-art therapy program. CACs are wonderful places. However, no place is infallible, not even CACs. CACs can and have done harm. I was part of a terrible incident at a CAC in which over 40 children suddenly lost their mental health providers. Many children were harmed. These children had been abused by parents, people they loved, and people they trusted, but they had found a safe space with therapists at the center, an adult they suddenly could trust. And the sudden loss of that therapist was an additional trauma. The lack of required continuity of care plans at the CACs allowed this harm to occur. These kids required more than just a new therapist. They required a goodbye with their old therapist, an understanding of what happened, and a new therapist trained in the treatment they were receiving. None of these children received these basic tenets. No one and no entity could help us. We contacted the National Children's Alliance. I have emails where they said there was nothing they could do. We contacted the Maryland Children's Alliance. We contacted the psychology and social work boards. We contacted the media, the county council. We even hired attorneys to see if we could, if there was anything that we could do to have contact with these kids and make sure that they weren't harmed by us missing in action. No one could help. No one was able to allow these children to have the option of discharge session or allow us to fulfill our ethical duty and our human duty. We have many, many emails showing our efforts. This bill is needed. This bill aims to provide much needed oversight to CACs. It forces strong policies to protect kids and providers and will provide tracking of problems, a mechanism for complaints and investigations. I leave you with one reminder. This bill was brought forth out of the ashes of the destruction that occurred back in September of 2020. However, its purpose is to prevent such a harm for any child related to a child advocacy center in the future. For over 3.5 years, no one has been able to do anything regarding these children and regarding preventing this from happening again. Now you have the choice to support this bill, and please do something.
Thank you. I know we have a little bit of a problem with the audio. When the 2 minutes are up, please wrap up because the bell is not ringing. Something's happening with it. So please watch the timer, okay?
My apologies.
Oh, it's okay. Next, please.
Hi, my name is Dr. Renee DeBoard Lucas, and I'm a psychologist with over 15 years of experience and expertise treating children and teens impacted by trauma. I previously worked at a child advocacy center and helped support families in the aftermath of physical and sexual abuse. I believe strongly in CACs and their mission's focus on reducing and preventing childhood trauma. I'm here to speak in strong favor of House Bill 1100. This bill closes an important loop that currently exists where children may and have been suddenly and traumatically separated from their therapist if treatment ends unexpectedly. At the CAC where I worked, over 40 children and families experienced an abrupt and unexplained end to their existing trauma therapy when myself and several of my colleagues were terminated. Sometimes people ask me how I can do this work when I see so many children in painful situations. I love this work, and I do it because I can help children feel better. When my colleagues and I were terminated, I immediately worried for the impact on these children. I worried that they would think that I had abandoned them, that I didn't care, and that they didn't matter. I worried that one client who had experienced recent thoughts of suicide may be in danger when his treatment ended without warning. This family was matched with someone who was not trained in the child's treatment, which disrupted their care and made the family understandably concerned. Fortunately, this family was able to find me through LinkedIn. They were distraught at the separation and at the fact that they were denied information on how to find me. I still worry about the impact on the families that were not able to find me and who may still think that yet another person who was supposed to care for them abandoned them. I care deeply about my patients and my ethical duty to do no harm. It was devastating to be prevented from upholding my duty, which I typically would have exercised by informing my patients of my departure and by having a termination session. The children and families seeking care at a CAC have already been through enough. They deserve to be treated with dignity and respect and to have this current loophole closed. Please support House Bill 1100.
Thank you for the work you do, all of you, and for being here today. Who is next, please?
Good afternoon. My name is Kelly Champion. I am a board certified psychologist in clinical child and adolescent psychology. I have over 20 years of experience teaching, researching, presenting on, caring for children. My specialty areas are trauma and treatment of adults. If the law was in place to protect these children, they would have been protected. If the law was in place to support professionals wrestling with an impossible ethical dilemma, we wouldn't be here with this bill. It would have been addressed. When professionals, psychologists, social workers, counselors, therapists sign up to take care of abused children, they sign up to take care of the most vulnerable, unsupported, betrayed citizens in our community. They need to know that there is stability. These children have been harmed in a way that's likely to have pervasive and significant impacts on their future psychological, educational, social, and emotional development. They don't have a voice. Children don't have a voice. Abused children have less of a voice. The person who was there to take care of them is the source of their trauma. The only person that can fight for this child's care is potentially the person who caused the trauma. If we need institutional coverage and support and oversight, it is for these children, and the professionals who sign up to this are, as Dr. DeBoer pointed out, confronted by our colleagues about why in the world do you do this terrible work? And we do this work because we're passionate about it, and these are extremely competent professionals. And to be working for an institution that puts them at harm of violating their legally enforced responsibility for their patients is a gross error. And I hope with this bill, you will change that circumstance for these patients.
And thank you again for your work. Who's next?
Madam Chair, members of the committee, Dan Shattuck here on behalf of the Maryland Psychological Association. I wanted to just take a couple moments to address some of the issues that Delegate Cardin raised with respect to the opposition. This bill is new to this committee, but we think this is the right home for this issue because it is dealing with the mental health and behavioral health of these children that have been in some cases thrust into the court system. But that doesn't take away the mental health and the behavioral health benefits that are being restored by these providers that we have at the table today. You'll see in the testimony of the opposition that they're saying that this bill creates a new definition.
Can I ask whoever that is, can you turn it off, please? And while that's happening, can we just check and make sure it's off?
Sure.
I did the same, don't worry, it happens to me too. And there's someone here who it happens all the time. Go ahead. Go ahead.
I think that's my penance for throwing a chair earlier.
Go ahead.
So I just wanted to reiterate what Delegate Cardin had said, that the definition of child advocacy center that is in the bill is not a new definition. Child advocacy centers are defined under the Health General Article, Section 132201, and that's the section of law that references the Child Abuse Medical Providers Initiative. And the definition that's used in the law is the definition that carries on throughout House Bill 1100. The other thing I wanted to point out is that even though the Department of Health's letter of information references the criminal procedure article and the governor's office on crime, violence prevention, that entity is more focused on the funding and making sure that the grant monies get to the child advocacy centers. When the rubber hits the road, it's where the providers and the children are working together. And we want to make sure that that's the focal point. This bill, as has already been said, will bring attention to that, will provide some much needed oversight, transparency, and it's something that'll benefit the providers, the families, and the children. Thank you.
Thank you. And thank you for respecting the time. Who's next?
Madam Chairman, Barbara Brocato, here also on behalf of the Maryland Psychological Association in support of House Bill 1100. I want to speak to just a couple points because, again, in the opposition statements, if you look, there's a thread that goes through them. This is a solution without a problem. We disagree. These are public functions. These are public dollars. There is no state framework to look at incidents and errors. Every system has them. Hospitals have errors, nursing homes have errors, systems have errors. And this bill is an effort to address those errors. So I would just, again, repeat what's been said before. Please look at the personal experiences in testimony that you have before you. And we're here to answer questions and ask you to pass this legislation. Thank you.
The next witness, you're unfavorable?
Me?
Favorable.
Yes.
All
We're-
of you are
we're all
favorable.
favorable.
I'm missing someone. I have
had.
I have Stephanie Wall,
We had two online.
right? I have Barbara Brocado, Daniel Shada, Kelly Champion, Renee DeBoer, and your name.
I'm Stephanie Olarte, but I was not able to sign up.
Oh, that's why I don't have you. Yeah, so you're not able to. All right, great. I'm going to open it up for questions now, okay? Are there any questions, Delegate Woods? Delegate Vice Chair Collison, and if you have any questions, let me know, okay?
Thank you, Madam Chair. So I'm a little bit struggling with this because clearly I'm hearing about the termination. I'm not hearing a lot of information about the termination. And I certainly would have a concern if a person is terminated due to ethical violations, professional misconduct, failure to follow agency policies or procedures, negligence, breaches of confidentiality. My concern is this, that worker may have established a good rapport, may have established a trusting relationship, but the nature of the violation may merit that they not have contact with clients. And so that's the first question I have. And the second question is.
Can you let them answer the first one?
Sure, thank you.
Go
So
ahead. Thank you, Delegate.
I'll let Ms. Wolf reply, but let me just say that that's not the intent of the bill, is not to stop somebody from being terminated. It's if they are terminated, there is a policy to either have there be an exit interview or to make sure that it is communicated to the individual, the recipient of the services in a prompt, timely way. And if that's not happening, then you're putting the child in harm's way. So the fact is, in this case, it was not because of any kind of violations, ethical violations, or duty of care violations. It was because they were terminated for other reasons that had nothing to do with their professional work. So, but the idea, so I'll let them respond, but the idea of this is to make sure, forget about whether they're terminated or not. That's fine. They want to be terminated, be terminated. Just make sure that the child is not put in harm's way because of that.
And Delegate, only one person is allowed to respond. So if you know that they're the best person, please let them do it. I will ask a follow-up. Go ahead, ma'am. A follow-up to the Delegate Woods question.
So I would say that absolutely, that if there was malfeasance by a psychologist, by social worker, any therapist, then there may be cases where it would be completely inappropriate and against the child's interest to have that termination session. However, it still needs to be handled with care, and there needs to be a continuity of care plan that allows for that child being informed immediately, that child of something that would be appropriate, and then also helping handle that termination with another person to kind of process it with them, and then be connected immediately with similar services. So, you know, that is an unlikely scenario, but it could happen. And this bill is not requiring that if somebody was fired or let go because they did something terrible, you know, that could harm a child, that they would be then encouraged or even allowed to have a termination session. But there are so many situations where terminations happen for a variety of reasons. And there's all kinds of situations beyond this state that's in the papers where the closing of clinics, et cetera, where people lose their jobs and then there's no continuity of care. And so given the vulnerability of the kids that we're talking about, making sure that there's a plan. And there should be a plan for that scenario too, right? What do we do as a CAC if, the worst thing possible, that a therapist is doing something terrible that could harm a child? There should be a plan about that too.
Delegate, absolutely. You're welcome.
So yes, and I am in agreement. But I guess my question would become, would it not be more favorable to have that continuity of care plan in place, as opposed to saying we want to? Because I'm still a little I'm still not clear as it relates to you saying someone being terminated abruptly. There was nothing to explain to me what would lead to these abrupt terminations, right? And in my work, you do have to have a care plan in place. We do have to have a backup plan in place. So I'm wondering if it's not more favorable if we just made sure that in all of these services, we have those buffering plans in place, as opposed to, again, because I'm still not quite clear about the whole termination piece. So
thank you. I think you raise a really good point. And I think what came to mind with that question is, in fact, if you're in private practice, you are required by law and ethics to have a plan for your own sudden death. So you certainly can't come back and have that gentle thing, but something needs to be in place. The reason for this bill is because there's no oversight. There's no checks and balances. The CAC, I don't know why it doesn't fit under the hospital, isn't making sure that the policies are in place. And what happens is you create this horrible ethical dilemma where, as you said, your work, my work, all of our work, we are obligated to know that the plan is in place. And if you're employed by a government-funded institution that doesn't have oversight, that is not adhering to these policies for many reasons, some of them less attractive than others, then that creates a horrible dilemma for the providers. And what you're losing is not only the children, and what you're not only creating is a situation where children that are vulnerable to horrible outcomes get another institutional betrayal. You're also losing the most qualified professionals. People that come in to do this work are heroic. They've gone into care. Most of the people trained in therapy don't know how the child maltreatment system works, doesn't know the impact. And so the few of us that end up doing this have a real passion and commitment to doing it. And we need to know that the whole system is supporting that treacherous work.
Sure. I know this is you do this work. It's okay. I respect that. Go ahead.
So then my question becomes, would it not be, again, more favorable to bring these groups together first before we put this type of legislation in place, to not bring these groups, because there's so many different, you're talking about so many different scopes of practice. You talk psychiatrists, psychologists, social worker, licensed professional counselors. You have all of these people who fit in, who we need to, you're saying no, who we need to bring together because there's no one size fits all.
So there's no need to reply to that question. And I'll tell you why, Delegate.
I'm sorry.
You jump the gun, however the expression goes. Because I have been meeting with the Department of Health, and I gave instruction to our lawyer that this bill will be in subcommittee and it will be a work group, because the Department of Health, there are different agencies, right? There's the governor's office of crime control. There is behavioral health. There is DHS. And this is almost the end of session, right? And it's such an important bill because, yes, there are two sides. However, these are the most vulnerable children that they are dealing with. And the federal government is the one that regulates them, and there's no regulation at the state level. So it's important, like you have a child abuse hotline, as you know, because you do that work, for us to look into this. It's not that we're taking a side, but to do it in an intelligent manner where we bring everyone together and we spend the summer, and I'm going to be assigning you to that work group. I am, and I believe Delegate White Holland and Delegate Bagnall and Gazzoni will be on that work group. They don't know it yet, but in any event, And Delegate Shalega. So, it's like, so you're gonna have, it's gonna be well represented and we're gonna look at the issue, okay? So with that in mind, as we move forward with the questions, that is what I have in mind, and I'm waiting for the Department of Health to send the language to our lawyer and myself, okay? Thank you. Okay, are there any other questions? Any questions from anyone? All right, seeing none, let's move on to the next panel. You have any questions? Okay. So, 1 second, we have an unfavorable panel, Neil Harkanis and Jubelki Radigan.
Favorable.
Unfavorable, I know, that's what I said.
Okay, great.
Okay,
Thank you. Good evening, Madam Chair and members of the committee. My name is Neil Karkanis here on behalf of the Maryland Children's Alliance. The Maryland Children's Alliance is a nonprofit organization that serves as a convener of the 24 child advocacy centers across Maryland. There's a CAC in every jurisdiction in the state. So we do greatly appreciate you making the time on this important issue today. Like I said, we're in respectful opposition to the bill. Welcome a work group. I'm waiting to hear from my client on that issue in particular, but if this committee chooses to move forward with the work group, we'd be happy to work with all the stakeholders in the interim to address these issues.
and we are, and I am going to be asking for your cooperation.
100%.
That the bill goes through, that it goes through in the Senate, and that we get this done. Otherwise, you will find yourself here again next year.
100%.
Okay.
We're committed to working with this committee and the other stakeholders that are involved in this, because as you know, it is incredibly complicated. There's 24 CACs. They are made up, their organizational structures are all different. Some are nonprofits, some are run by the Department of Human Services, some are run by counties, some are run by law enforcement. So I think it's really quite wise choice to study it further, look at continuity of care, look at quality of care, all of those things. Those issues are covered under licensure for psychologists, for social workers, and other folks that provide these important services in CACs. But I'll keep my statements short. I think we'd appreciate that way forward.
Absolutely. Thank you. And thank you for understanding and agreeing. Thank you. Go ahead.
Hi, good afternoon, and thank you for pronouncing my name correctly. I haven't heard that in a long time.
My sister's, that's her name.
Oh, wow, we have to
She
talk.
spells it a little differently, but that's her name.
Yes, well, thank you. Good afternoon, Madam Chair and esteemed members of the committee. My name is Juvelki Radigan. I am the Director of Clinical Services at the Center for Hope. The Center for Hope has the largest mental health behavioral health clinic in Child Abuse Center in Maryland, one of them. We provide free, unlimited services to the most vulnerable people in Baltimore City, ranging from victims of child sexual abuse all the way to homicide, child homicide survivors. It is important to note that we are committed to protecting our clients. We are not in the business of re-traumatizing our clients. And we do believe and we do honor, the multiple requirements that require us to care for our clients with the high sensitivity and protection. So that is not what we are advocating for. There are several concerns with this bill, primarily that it is duplicative, it is redundant. My entire team, my entire department, everyone who contacts and treats a client at the Center for Hope is licensed. And there are multiple systems of oversight, and there are multiple standard operating procedures that would prevent any inappropriate behaviors by a clinician. And should that happen, then I am required by law to report it. And if I don't, then I risk my license. So please know that all the professionals, we are licensed and we adhere to accountability measures already managed under the Maryland Department of Health. The Department of Health already has mechanisms in place to investigate Medicaid fraud and insurance fraud. And yes, our CAC is managed and has standards endorsed by the U.S. Department of Justice and many others. And for the sake of time, I'm open to questions, and I too agree that I would love to be part of this working group because I have a lot of thoughts on this. My time is up, but there are three final points I would like to make. The way Child Advocacy Center is defined in this bill is vague. There are many organizations, hundreds of organizations that would fit what they're calling people who investigate, diagnose, and treat children. That includes CPS. They're the ones that help with the investigation. So it is unclear in this bill, would the CPS staff also be under this legislation? That needs to be clarified. Second final point, which is, oh yes, it is also unclear. I have a huge curiosity, which is why aren't the licensing boards enough? What is the problem that we are trying to legislate, and why does it require legislation? This is where the working group would really be beneficial to really parse out some of those really large curiosities that merit some consideration. Again, I'm open for questions. There's so many more points I'd like to make, but in respect of everyone's time, I would like to ask that we do an unfavorable report for this bill.
And thank you for your testimony. Are there any questions? And I delegate, before I go to questions, I believe that the reason why the licensing board are not enough because it's not about the provider per se, but the center, the system, and that's the reason. Can I ask you where is your last name from?
Oh, well, my maiden name is Rivera, so I'm my married name. Yeah.
Okay, because my sister's is from Dominican Republic.
Yeah, I'm from the Dominican Republic.
I thought
also.
so. I didn't want to assume. My
There's only
husband,
very few.
my
very
husband
few
always
you
says,
vote
"How can you tell?" Because we're in a
The name.
supermarket, and I go, "That's a Dominican person," and he's like, "How can you tell?"
Yes.
Anyway, I thought so. I didn't want to assume.
No worries. No, it's
Is-
very obvious. The first name.
So is your nickname Juby, like my
Yes, it is.
sister?
Yes, it
All
is.
right.
Can I make a
No.
point? Can I make a point about the the licensing boards? So my jurisdiction is there are the mental health, providers. And my understanding of the precipice of this bill was the ethical dilemma. And so another question that comes up is, are we prepared to legislate all ethical dilemmas, right? An ethical dilemma is a choice that the provider has to make. And we're encouraged to honor our ethical standards. And so that, in my opinion, is different than all the requirements that we have to honor professionally. And so the working group can also get into unpacking that a bit, but all of the professionals at mental health at the Center for Hope, they're all licensed. We have weekly and individual supervision. Termination, whether it's sudden or planned, does not typically lead to like abandonment of client, which is an ethical breach, which again, the board can look into, but those are few and far between, and they don't happen at Center for Hope.
Yeah.
We have a lot of systems in place for the licensed professionals, which is my expertise.
So, Ms. Radigan, my grandmother, who was Dominican, used to say that a story has three sides.
Mhm.
So this is why we're here.
Yes.
Delegate Bagno, followed by Vice Chair Collison.
Thank you, Madam Chair, and thank you for your comments, and very respectfully, I don't think that this bill is an attempt to malign any particular agency or even child advocacy centers, as a whole. I think it's to try and look at child advocacy centers through the lens of continuity of care.
Yes.
And patient-centered care. And we recognize it's complicated. There's a lot of agencies, there's a lot of oversight, but even as adults, we are challenged to navigate the healthcare system, right? We're challenged to navigate the insurance market. And so I think we want to look at this work group and this work before us through the lens of a child, a traumatized child who's trying to navigate a system And we have to build that system and make sure that we have proper oversight for the system itself, because we know that we have oversight for the providers. So I would just ask respectfully that as we approach this work, that we're all sort of looking at it through that lens.
Okay, I have Vice Chair Collison followed by Delegate Taylor.
And I'm going to associate myself with the comments of Delegate Bagnell, but I'll tell you why I'm concerned. I mean, I think the chair is absolutely on target when she says we have to look at this, but you know, mental health for this particular population is absolutely essential. We have a dearth of mental health providers in this state, but then when I hear that 5 of them are terminated from a center, I'm like shocked. How can that be? Unless they were doing something horrendous. So that to me raises the question of oversight. What is happening that we could afford to lose 5 psychologists who are actively treating children? So I don't know, you don't actually have to respond to that because I suspect, you know, there's some proprietary information, but I think that's what led me to be very concerned.
I'll just say, Delegate Collison, there's active litigation on that matter with a specific CAC. Happy to connect with you offline with additional facts should you want them.
Thank you. Okay. Delegate Taylor.
Thank you, Madam Chair. Just for the panels, just so you'll know that I and my colleague are from the Judiciary Committee. And it's such a coincidence that today I would be called to serve here in HGO when my neighbor, UV Radigan, serves on a panel. She also serves as our HOA vice president. So I just really wanted to say, welcome to my neighbor.
Hi, neighbor. Hi, and you are all welcome. This is very complex, and I would happily, you know, join my esteemed colleagues. Again, we are in the business of oversight. It is, you know, I'm very, very clear about ethical and licensing requirements. So I do care for oversight. Agreeing and very respectfully, absolutely. And hi, neighbor. And you are all welcome to the Center for Hope. We have so many standard operating procedures that I would be happy to share to see if it would be helpful in any way.
And I'm happy to extend that invitation across all the CACs. There's one in every jurisdiction in the state. There's everywhere you are. So happy to help make that connection.
And I appreciate what you all are saying. I just hope that I want to affiliate myself with Delegate Bagnall's comments, because as you all move forward, I think what should be clear is that there has to be oversight from the government, and that has to happen. And the question is, what is it going to look like? Not that we don't need oversight. You need oversight, and we're going to have to provide it. So we need to figure out how that's actually going to happen. So isn't that so? Thanks.
All right. So there are no other questions from the committee. I just want to say thank you for your testimony, for being open to receiving it and sitting at the table. And everyone else, my hope is that we can come up with language. I know the Department of Health is helping drafting it, where we can look at certain things in a balanced way and then go over to the Senate and pass it. And my hope is that you will be supportive in the Senate and say, we will do this and sit down, because otherwise you may not like what we do, right? Next year. So I think I always say, and people know I always say here, you get more with honey than you do with vinegar, okay?
100%. Right.
And thank you for being willing.
Yes, thank you for your kindness.
You're welcome. Have a blessed evening. We do have a favorable panel of 4 witnesses that are left virtually. Will you be so kind and bring them up, please? They're there? Anyone that is there, will you be so kind and unmute yourself and give us your testimony? Ms. Carlton, you can get started. You're welcome. Have a blessed evening.
No, that's all right.
Good evening, and thank you for having me here today. My name is Dr. Jenna Calton, and I'm a psychologist who specializes in child trauma. I'm here to testify with strong support for HB 1100. I completed pre- and postdoctoral training at a CAC and worked as a psychologist at one for several years. I know firsthand how critical CACs are. I've witnessed them help countless children. However, I was part of an incident in which dozens of kids abruptly lost their mental health care providers at a CAC. The effects of this loss were profound. Children felt confused, scared, sad, angry, hopeless, helpless. The same feelings brought on by the abuse that led them to the CAC for help were happening again. But this time it was because of a CAC, a place designed to do the opposite, a place devoted to trauma-informed care. One teen affected told me she was scared and mistrusting of the system before this. Afterward, she felt more scared, did not trust anyone connected to the CAC, and all she wanted was to locate her therapist. Someone it had taken her months to build a trusting relationship with, who was helping her with debilitating symptoms of post-traumatic stress, including thoughts of killing herself and panic attacks. She begged her mom to find the psychologist, but when her mom requested that psychologist's information, it was not provided. Instead, she was referred to another facility to wait for care. The message was clear: she was alone, no psychologist, no CAC. This is one example of the detrimental effects that have happened and could have been prevented. With additional oversight, she may have received the continuity of care that she deserved. This bill aims to protect youth who need trauma-informed care, including a smooth transition between therapists, one that is planned, unhurried, and provides kids with a choice of how to proceed. Please support this bill. Thank you.
Thank you, and thank you for being here today. Next, please. Just unmute yourself, anyone. All right.
Hi, my name is, thank you, Madam Chair and members of the committee. My name is Richard Block. I'm an attorney practicing in Maryland since 1972 and have represented the Maryland Psychological Association since 1979. I'm here on behalf of the Maryland Psychological Association. I've been here during last year's hearing and on today's opposition to the bill, and I've heard the justification of the opposition that CRCs are certified by the National Children's Alliance, that the incident that occurred was unique and therefore this legislation is unnecessary. One example is sufficient to make us aware of the lack of oversight that exists. National Children Alliance member CACs are credited for 5 years. I have reviewed the documents on the National Children's Alliance website to try and find a process by which a complaint could be filed against a CAC accredited by the Alliance. I reviewed the books on their standards and their membership guidebooks and was unable to find any reference to complaints or process for filing one. The oversight of these facilities by the Department of Health is critical to protect the mental health of children who are being treated by CIC mental health providers, whether employed or privately contracted. The negative impact of the sudden loss of a mental health provider can be overwhelming to children who have established trust and reliance on their therapist. This bill simply provides a process for those instances and requires CACs to provide information to the Department of Health and appropriate oversight of CACs to assure they are providing for the ethical transition of children's treatment, which is an obligation of every therapist. And as noted, if the therapist is terminated and prohibited from contact, they are unable to comply with their appropriate ethical responsibilities. Therefore, this bill is important, and I urge you to favorably report on HB 1100, and I am offering to serve as well on this workforce if that's what occurs. Thank you, Madam Chair.
Thank you. Next, please.
Good afternoon, Chair Pena Melnick, Vice Chair Cullison, committee members. My name is Dr. Bill Fluke. I'm a retired psychologist. Over the past 50 years, I've devoted my career to addressing the learning and mental health needs of children in school, including service at the Maryland State Department of Education and with Baltimore County Public Schools. Speaking today with the for the Maryland Psychological Association in support of House Bill 1100. As you've heard, the bill will bring appropriate health department treatment standards and accountability to the behavioral health services provided to abused and traumatized children at our child advocacy centers. In my experience in working with these children in our schools, many have experienced such trauma that their executive functioning and learning skills are damaged, and the research supports this observation. Executive functioning includes the ability to concentrate, to focus on learning, but it also involves emotional and behavioral self-regulation. Without effective, high-quality treatment, many of these children will perform more poorly in school, both academically and behaviorally. And abused and traumatized children are at greater risk for presenting with serious discipline issues, as well as being identified as disabled and in need of special education services. In order to ensure the best treatment and the best outcomes for these highly vulnerable children, we request a favorable report on House Bill 1100. Thank you.
Thank you. Next, please.
Good afternoon, Chair Penemelnik and Vice Chair Cullison and members of the committee. It is good to see you again and have this opportunity to address you today. I am Dr. Pat Savage, a retired psychologist in Maryland, the immediate past chair of MPA's legislative committee, as well as a past president of the association, and have practiced for 40 years serving children, family, and adults in Montgomery County. Today, I am testifying in strong support for House Bill 1100. You have already heard that HB 1100's intent is to take a step towards requiring accountability from organizations providing mental health services to our citizens. It's a simple ask to ensure that the behavior of organizations is consistent with the standards of care and ethical principles required of mental health therapists. Our goal is not to impugn the good work that organizations like the CACs do, but to take another small step towards, quote, building a world-class mental health system in Maryland, unquote, a goal that I know is shared by all of you on this committee. You have heard from others about the harm to vulnerable clients and families. I won't reiterate that. I will focus on the potential harm to mental health providers. Preventing therapists from providing appropriate terminations and interfering with the continuity of care of their clients potentially places therapists in grave danger with their licensing boards. It can be called abandonment. Abandoning one's client is not a position I would like to defend in front of my licensing board if I was charged with such an offense. Such a charge can result in a loss of licensure. To be clear, licensing boards can only discipline mental health therapists. They cannot intervene with nor correct administrative decisions made by organizations providing mental health care. That point has been misrepresented to you. The boards have no direct ability to protect kids or families from organizational decisions, only to protect them from unethical or poor providers. Enacting this legislation will encourage mental health clinicians to participate with organizations such as the CACs, not discourage them, as some have and may say to you in testimony. We all know that we need to encourage qualified and competent mental health professionals to provide services in Maryland. I ask that you join us in taking yet another step towards building that world-class mental health system in Maryland by providing a favorable report on HB 1100. Thank you so much for this opportunity, and I would serve on the work group and be available for questions as well.
And thank you for being here with us and all of you for making the time. I'm going to open it up for questions now. Are there any questions for this panel? Seeing none, thank you very much for being with us. This actually concludes the bill hearing on House Bill 1100. Thank you very much for being with us. Have a great evening. We still have, I'm going to call now, 1 second. Is there someone here for House Bill 1497? I'm going to call that one. That is State Board of Massage Therapy Examiners, scope of practice, reinstatements, and examinations by healthcare providers. Go ahead. So I am not providing any testimony. They are providing the testimony. I put in the bill for the board. Go ahead. Please, if you can get started on House Bill 1497.
Good evening, Madam Chair and members of the committee. My name is Stephen Conti. I'm the Vice Chair of the Massage Therapy Board, and I'd like to thank you for the opportunity to testify in support of House Bill 1497. House Bill 1497, if enacted, will authorize massage professionals to use handheld tools during a massage therapy treatment. Number two, it will require applicants for reinstatement of a license or registration to submit a criminal history background check. And three, authorize the board to require applicants or licensees to submit to an evaluation by an independent healthcare provider should the board deem this necessary to protect the public from a potentially harmful massage provider. Massage is a very physically demanding profession where the average career span for each therapist is approximately 5 years. Instrument-assisted soft tissue manipulation with proper training will extend the work life of the massage professional by reducing injuries to the provider's joints, hands, arms, shoulders, and back. Longevity of the practitioner in the profession ensures continuity of care for their patients and a level of expertise of years experience that brings. The constant and rapid evolution in the types, use, and availability of the handheld tools used in the delivery of massage therapy services necessitates clarity for both the massage consumer, the public, and massage professionals. Specifically, we seek to clarify that during the course of a massage treatment, handheld tools can be used. These tools are not only used by massage professionals, but also by athletic trainers, physical therapists, chiropractors, acupuncturists, and doctors. Requiring proper training in the use of these handheld tools by massage professionals elevates the quality of care provided and ensures the protection, well-being, and safety of the public. Next, in regards to the process of reinstatement for a licensee or registrant who is returning to practice from a non-renewed or inactive status, we believe it important to have the full picture of the applicant. This includes a criminal background check. Criminal background check requirements went into effect for massage therapy applicants on October 1st, 2016. There were no retroactive provisions in the law requiring approximately 3,000 active and practicing licensees or registrants to be fingerprinted. Should an individual who is non-renewed or inactive status and never fingerprinted elect to return to practice, this law would ensure a comprehensive criminal background check is completed and aid in the implementation of RATBAC for the massage professional. Finally, the board is seeking to come in line with other health occupation boards, including the physician, acupuncture, and the pharmacy board, all of whom are authorized to order evaluations from independent healthcare providers for their current licensees and applicants. From time to time, the board may have reason to believe an applicant or licensee may cause harm to the safety and well-being of the public. In those instances, the board deems it prudent to obtain an independent evaluation by the appropriate healthcare provider to determine fitness to practice massage therapy. The primary focus of the board is protection of the public. The board will assume the costs of the evaluation with no economic impact on the licensee or applicant. For these reasons, we are seeking a favorable vote on House Bill 1497. Thank you.
Thank you. Are there any questions for this witness? Okay, seeing none, thank you. And just for the record, we reach out to the community just to see if there was anyone that would object to the bill. There was only one person, and it was regarding the cupping. So I spoke earlier to the board that we're going to have a small amendment regarding that in subcommittee, okay? Other than that, we didn't find any opposition. Since there are no questions, this concludes the bill hearing on House Bill 1497. If you will be so kind and stay there, because you're going to do House Bill 1498, State Board of Massage Therapy Examiners, aiding or abetting unauthorized practice prohibition. Why don't you get started?
Yes.
Thank you, Madam Chair, and good evening to the members of the committee.
I spoke to you earlier.
You did.
Okay, go
Yes.
ahead.
I'm Sharon Oliver, for those who have not met me before, and I'm the Executive Director for the Massage Board. We thank you for the opportunity to testify in support of House Bill 1498. This bill seeks to ensure that aiders and abettors of the unlicensed practice of massage therapy are prohibited from engaging in this activity. And in considering the aiding and abetting of unlicensed practice, there are three main areas I would like to focus on. One, safety, public safety. Two, harm to the state's economy and the massage profession. And three, impact on board investigations and resources. To be clear, this bill is not aimed at punishing the unlicensed massage service provider, recognizing that oftentimes this individual is a victim of human and labor trafficking. The objective of the bill is to target those individuals who aid and abet unlicensed practice and to provide local and state law enforcement with an additional tool to keep the massage consumer and professionals safe. Aiders and abettors of unlicensed practice are not concerned or interested in ensuring that the massage service providers are properly trained, educated, understand the risk and the benefits of massage therapy. Improperly trained or untrained providers do pose an imminent danger to the safety of the public. Nor are they concerned with the safety of the individuals themselves who actually provide the massage therapy service, some of whom have been subjected to unwanted advances by their clients or forced into prostitution. The economic impact of unlicensed practice on the state's economy, legitimate small business owners, and individual massage therapists cannot be understated or overlooked. Owners of unlicensed businesses not only divert revenue from the state's coffers by not reporting their income and paying their fair share of taxes, they shift the tax burden to the hardworking, tax-paying citizens of Maryland. They hurt the legitimate business owners who have invested their time and resources into building their practice by diverting clients, and in so doing, impact the revenue stream of our licensees. They place the physical safety of our licensees at risk, some of whom have been accosted by angry clients seeking non-massage related services. Further, public perception of the severity of the problem can result in regulatory boards developing reputations for inadequately addressing what admittedly is a complex and challenging issue. When given the opportunity to address do no harm, we accept this call to action to protect the public from the unlicensed. We owe it to our licensees who take their profession seriously and want to be recognized by this body as an integral part of the healthcare system for our citizens. In recent years, the board has seen an increase in the number of complaints related to unlicensed practice. Over the last 5 years, on average, 26% of the complaints we receive deal with unlicensed practice, shifting the focus of our investigators and resources to cases where we have no jurisdiction. To highlight the problem, in 2020, the board investigated a complaint against Lucy's Health and Acupressure Spa in Anne Arundel County. The case was closed and referred to law enforcement. Fast forward to 2024. A February 9, 2024 article in the Capital Gazette details the confiscation of $1.4 million in cash from the home of a spa chain owner following a federal investigation into prostitution and sex trafficking. This operation has 4 locations in Maryland, Lothian, Deal, Kent Island, and Dunkirk. A felony conviction for anyone involved in aiding or abetting the unlicensed practice with hefty fines, punishment, and/or imprisonment will act as a deterrent and provide a much-needed tool for local and state law enforcement to pursue these individuals. For the reasons stated, we are asking for a favorable report on House Bill 1498. Thank you.
And thank you for your work and for your testimony today. Are there any questions for this witness? Yes, Delegate Johnson.
Thank you, Madam Chair, and thank you for coming to present this bill to us. My question is, it says in here, we know wording is very important. And it says in here, practice of massage therapy. Now, there have been a lot of establishments opened up that have a different name, but it's supposedly a massage establishment under the name of spa. And a lot of these are areas where you find prostitution or human trafficking. So would those be covered under this bill?
Yes, if we receive a complaint or if the law enforcement receives information that someone is practicing and it is discovered that the owner or the person aiding and abating the unlicensed practice of massage, that would cover that.
Thank you for the question. Any other questions? The Delegate Shalaga.
Thank you, Madam Chair.
You're welcome.
So I'm reading the bill and it says that currently a first offense, a fine not exceeding 2,000 or imprisonment not exceeding 6 months, subsequent 6,000. Has this been applied? Has this fine been levied on people?
For clarification, the aiding and abetting of the unlicensed practice is different from the unlicensed practice of massage therapy. The section you just referred to is for an individual who is unlicensed and is practicing. It's not against the aiders and abettors. This is the first time we're bringing this law or this proposed law for aiders and abettors. And we're looking for a felony versus what is currently a misdemeanor for the unlicensed practice of massage therapy.
So are you finding that the current law is not adequate? I know you're talking about aiding and abetting, but
It's not
there's
adequate.
still a person that's practicing.
No, it's not adequate. We have other examples, recently another individual was arrested by law enforcement and the law enforcement officer, while he was waiting to transport her from to the precinct, allowed her to call her husband and the phone was on speaker and he reported this to the board. And during the conversation with her husband, the husband basically said to her,
Don't worry.
it will be just like last time. Nothing is going to happen to you. You will get a stet or PBJ. This was her third arrest for.
So that no one applied the 2,000 or 6 months. That was not
No,
applied.
it was not.
The courts are not imposing this.
Because it's a misdemeanor, sometimes it's difficult to get the case advanced to the point where it will go to a trial to impose these fines. A felony is different.
Thank you.
Okay, thank you. Delegate Taveras.
Thank you, Madam Chair. Ms. Oliver, what is the potential number of locations that you could have prosecuted before, like as far in the last year or two that you've been aware of or have not been able to close?
Last year in 2023, we had 11 cases that were referred to law enforcement.
Quick follow-up, if I may. what occurs to the individuals, whether male or females, that are being trafficked typically? Like, how do you deal with that in order to ensure that they're not caught up in the process of the fines?
We don't have any jurisdiction in that area. If we receive a complaint about the unlawful or unauthorized practice of massage therapy, we complete the investigation. There's nothing the board can do. We turn the information over to law enforcement for them to pursue. Ironically, if this law was on the books back in 2020, more than likely, this business owner that had $1.4 million in her home, the state could have used this law to go after her and in all likelihood, prevent the spread of her business from what it was then.
Thank you.
Any other questions? Interesting enough, while Delegate Shalega, before she asked you the question, I sent Lisa Simpson, who's the lawyer and is listening to these proceedings, a text, and I say, can you look at the other occupation boards, the fine, to see if the fines are similar? Because I noticed that second is not the first time that I'm concerned, it's the second one as well. So it may change in subcommittee, just letting you know. But you will be welcome to go to subcommittee. I did ask for the bills to be placed in subcommittee, and I believe they'll be in subcommittee tomorrow. So make sure you touch base with Michelle and you can get the link, okay? Because I need you to do that. And then if they pass, God willing, they go to the Senate and you're gonna have to do the work over there as well, okay?
Thank you.
My pleasure. I don't see any other questions regarding these two bills. This actually concludes the bill hearing on House Bill 1498. Thank you so much for being with us today. And now we're on to the last bill of the evening. And thank you for those brave souls who have been waiting to be called for House Bill 1194, Delegate Y. Holland. Hospitals, Clinical Staffing Committees and Plan Establishment Safe Staffing Act of 2024. And Delegate Holland, will you be so kind and bring your panel? You're welcome.
Just bringing up an extra chair for my panel. All right, but I'll go ahead and get started. So again, good evening, Madam Chair, Madam Vice Chair, colleagues. I guess saving the best for last here today. And my fellow colleagues of the House Health and Government Operations Committee, thank you again for the opportunity to present.
Will you allow me to just say something before so I don't
Yes, ma'am,
interrupt
I'm
you?
sorry.
For the committee members, those that are here or in the back getting something to drink, we will be voting tonight. So, you know, after we're done with the bill hearing, we have a little bit of, we have to put the files together, right? For the bills, but please hang around because we will be voting tonight. Okay? Thank you. Go ahead.
Okay, thank you again, Madam Chair. And again, thank you for the opportunity to present HB 1194 for your consideration. I would also like to thank my panel for their patience in being here this evening. And I would also like to express my sincerest gratitude for the nurses in my community, including my own neighbor, who approached me in the interim, elevated concerns, presented solutions and shared feedback and expressed support, which led to this proposal before us today. And I would also like to thank the Maryland Department of Health for working with us and providing amendments that I will discuss momentarily and which should be passing around and making their way to you as we just received them from the Amendments Office. And so as a committee, as we all know, we are working diligently during session and in the interim, continuing to address ER wait times, increase access to primary care, and strengthen our healthcare workforce. This bill is another opportunity for the legislature to listen to those who provide direct care to patients, create safe working conditions for staff and patients, and retain the healthcare workforce. As it is currently written, HB 1194, the Safe Staffing Act of 2024, presents a hybrid approach that requires each hospital to establish and maintain a clinical staffing committee with half of its membership, including RNs, LPNs, CNAs, and ancillary members of the frontline team, assigns the staffing committee to develop a staffing plan, and includes enforcement mechanisms with the oversight provided by HSCRC. But at your desk, I will direct your attention to amendments that the Maryland Department of Health offered and that I consider friendly, and then submitted them as sponsor amendments. And so again, I would just bear your patience here as I review these amendments for your hearing that have been accepted. And so it essentially strikes the bill language and replaces the bill with the proposed language that you see at your desk. It exempts state hospitals from the bill, and it streamlines the process by which the hospitals establish and maintain their staffing committees and develop a clinical staffing plan. It also outlines the goal of the clinical staffing plan and the various factors that should be considered in creating that plan. On or before July 1 of each year, the staffing committee would then review the plan for effectiveness. Ultimately, again, this would eliminate the submission, as you can see, of the plan for HSCRC to provide the oversight, and removes compliance language by only requiring the staffing plan to be available upon request. Overall, these amendments simplify the process by which hospitals establish and maintain their committees and create their clinical staffing plans. Additionally, based on communications from the Maryland Department of Health, and I would be delighted to provide those if necessary, these amendments eliminate the fiscal note. As these amendments eliminate the 4 positions, salaries and fringe benefits, and operating expenses for the HSCRC to collect staffing plans, post these plans, investigate complaints, publicly post infractions, and submit a required report. Following the hearing, again, the sponsor, we all remain committed to work out any remaining issues and continue to be at the table, even ahead of subcommittee. And so as we look ahead to the ahead model, pun intended there, HB 1194 is a tool that will help hospitals meet performance measures related to quality and health equity. This bill offers flexibility. It does not require mandated ratios, but uses staffing committees and staffing plans as a hybrid approach to ensure that voices and perspectives of our healthcare workforce are at the decision-making table, make improvements to workplace safety, address staff turnover, and improve how we deliver care. I respectfully request a favorable report as amended, and I appreciate your consideration.
Thank you for your hard work and bringing everyone together. Thank you. Next, please. Turn it over to
Good afternoon, Chair Pena-Melnick, Vice Chair Cullison, and members of the committee. My name is Lorraine Arikat, Senior Policy Analyst with 1199 SEIU. We're the largest healthcare workers union in the country with 10,000 members here in Maryland. I want to thank Delegate White-Holland for championing this bill and coordinating with all stakeholders. 1199 appreciates being part of the work groups and commissions addressing healthcare workforce shortage and the state's long ED wait times. However, these initiatives fail to incorporate worker-led solutions for retention and job quality for the entire care team, including technicians, environmental service workers, and dietary aides. Despite retention bonuses, loan assistance repayment, sign-on bonuses, workplace improvements, and other benefits, hospitals are still severely short-staffed because these workers did not have a seat at the table. The healthcare workforce shortage is not due to the lack of nurses or healthcare workers in the state, but a lack of good jobs that retain and protect workers and allow them to provide quality care. The Safe Staffing Act of 2024 recognizes that those closest to the problems are also closest to the solutions that we need right now. This legislation has been implemented in 9 other states. 1199 members who are part of their hospital staffing committee in New York feel empowered being able to address ongoing staffing issues and providing better care to patients because of the committee's collaborative process. While safe ratios are important, these committees also have the potential to adjust assignments for staff, test and track the effectiveness of staffing strategies that fit patient acuity, and also yield data on retention and staffing conditions that will be useful to policymakers and state stakeholders. If we don't address the healthcare workforce crisis with tangible worker-led solutions, it will impact Maryland's all-payer model, be increasingly difficult for patients to get the care they need, health costs will rise, and it will be harder for Maryland to prepare for the next public health emergency. For those reasons, I urge this committee to issue a favorable report on HB 1194. Thank you.
Thank you. Next, please.
Good afternoon, Chairwoman and committee members. My name is Fabea Pollitt. I'm an environmental service staff worker at a hospital and a member of 1199 SEIU. Hospitals are short-staffed every day. It doesn't matter what department or shift. Everyone is working short. We are humans who need safe working conditions. I urge a favorable report on the Safe Staffing Act. EVC workers maintain sanitary environments, which is important for patients and worker safety. I claim 4 floors, including common areas, pharmacies, break rooms, and bathrooms. There are only 2 EVC workers in my building. When one call out, that means that we're responsible for the whole building. Our work is literally backbreaking. There aren't enough workers to empty trash cans on a regular basis. The bags are too heavy from being overstuffed. Workplace injuries are common, which makes short-staffing even worse. I was out for a month because I sprained my back lifting a heavy bag, and I'm still in therapy now. Workers are quitting because we are overwhelmed and disregarded when we raise concerns about staffing. The Safe Staffing Act gives us a voice. A 50% workers committee will ensure the staffing plan is successful. We all have a part to play, so we should all help craft the safe staffing plan. Please vote yes. Thank you.
Thank you very much. And thank you for your work, okay? Next, please.
Madam Chair and members of the committee, my name is Shaniqua Covington. I'm a unit operating room associate at a hospital and a member of 1199. Hospital workers want to make a positive difference in people's lives. We put the care in healthcare. It's hard to see our patients hurting due to chronic short staffing. So I am speaking out and urging you to issue a favorable report on the Safe Staffing Act. I prep and transport patients to surgery and assist the surgeons and nurses. Support staff like me are the backbone of the hospital. We are often the only ones that patients get to have a casual conversation with, and we are our patients' advocates. The operating room is short every day. We frequently reschedule surgeries, which is burdensome on patients who travel long distances and those who do not have paid time off of work. Waiting times to receive care, medication, and test results has increased. This impacts patients greatly. When a patient sits for too long in one position, they are at a higher risk of pneumonia, bed sores, and falling. This bill is the tool we need to fix short staffing because it requires that 50% of the Safe Staffing Committee be workers. We are the ones on the front lines of the short staff crisis. Therefore, we are the one with the solutions. Anyone can end up in a hospital. You would want your hospital to have a Safe Staffing Committee. If you did, please vote yes on this bill. Thank you.
Thank you for your work. I love your hair.
Yeah, thank you.
Go ahead.
Good evening, Robin Elliott here on behalf of the Maryland Nurses Association in strong support of this bill. I want to particularly thank the sponsor and the advocates for reaching out to the Maryland Nurses Association early, getting our input and really talking this through. And this is something that the Maryland Nurses Association fully embraces. I wanted to share just 2 primary points. The first, it was very, very important to the Maryland Nurses Association that the committee include all types of direct care staff. We of course know that nurses are a big part of the patient care team, but it includes everyone, including the witnesses on this panel. The second thing I wanted to note, and I remember this because I've been around for a while, but in 2013, this body passed a similar bill related to workplace violence. Very similar structure, a committee that includes direct support staff, members of the management team of the facilities. And this is really a great model. It's collaborative. It is productive and really looks towards real solutions and helps build that relationship between everyone in the hospital. So we ask for a favorable report. I will note you have in the testimony that I submitted some amendments. I think that those have been taken care of by the Maryland Department of Health's amendments. They were small, kind of just clarifying amendments. Thank you.
Thank you, Robin. All right, I'm going to open it up now for questions, okay? Delegate Hutchinson.
Thank you, Madam Chair. My question's for the woman to the right of Delegate White Holland. In your testimony, I think you made a comment that said that this would have, if this doesn't pass, it would have a negative impact on the all-payer model here in Maryland. Could you elaborate on that and how that would affect it?
Yeah, thank you so much for the question. Our all-payer model is really about making sure we're improving quality of care and minimizing readmissions into the hospital. Staffing is absolutely connected to that because they are the ones delivering care. And so often short staffing has led to lower quality of care. And there are research studies backing that up across the country. And so being able to have staffing plans that improve care can also make sure that we're reducing hospital costs and letting patients go home where they don't have to come back into the hospitals.
Right, Delegate Lewis.
Thank you, Madam Chair, and thank you, Delegate White Holland, for this bill, and to all your panelists, especially the ladies who took time off work to be here. I certainly hope that you are able to take advantage of paid leave, which is a law that we passed a couple of years ago. I just hope so. You don't have to answer, but I hope so. You shouldn't lose a day of income. But in any case, I remember we passed legislation to establish a work group to look at long emergency room wait times. It's called the Hospital Throughput Work Group. And my understanding is that group is working, and I don't remember if we've gotten recommendations yet or not from that group. But my understanding is that there were no hospital workers, frontline staff participating on that work group, delivering recommendations. It seems like a missed opportunity to get perspectives from people closest to the problem, short staffing and long ER wait times and all of that. And I wonder if this bill might close that gap, since we didn't ask workers when we had an opportunity. Maybe asking workers this time will make a difference. Do you see that as an opportunity to close that gap? Whoever's best to answer, Delegate, whoever you think is best to answer.
Thank you, Delegate, for that question. And, I would say, again, as what you have heard articulated by this panel is that, those that are on the front lines are the closest to the solution, right? And so I think any opportunity that we have to ensure that there's representation and their voices are heard as part of these committees. And in fact, some of our hospitals may already have these committees, right? And so it could very well find room to reconstitute that, to ensure that there's the representation necessary to ensure that those voices are heard. And so indeed, I do believe that this is an opportunity for us to move forward in that way. To ensure that those perspectives and those voices are at the decision-making table to inform what that individual hospital plan looks like.
Delegate Taveras.
Thank you, Madam Chair. Just to the 1199 workers, thank you for being the essential workers and working in the front lines. I don't know, whoever responds, you could let me know how long you've been working in this industry. But I'm curious to know in the past, what has happened when you currently bring your staffing concerns to management?
I'm gonna say, like I said, I work in EBC. I've been working in EBC for 20 years. We bring that concern and it's like they brush it off and just worry about the work to be done. They act like it's basically our problem that they're short-staffed it.
Delegate Hill.
Thank you, Madam Chair. And thank you, Delegate, for this great bill. I want to be clear, this amendment strikes the whole bill essentially. And it substitutes a committee that is less defined, but toward the same goals. And I guess what I'm confused about is, but I'm asking you as the sponsor, Ms. Elliott spoke to the importance of having not just nursing staff, and frontline staff, but all representative folks there. The new amendment doesn't speak to that at all. So your confidence that it's going to be composed as you would want with the proper people or people representing the whole range is based on what?
So thank you again, Delegate, for the question. And again, I did circulate. I'm not sure if you missed the packet that I had. I distributed an updated set from the amendments office, but what it will say is that there is an equal membership from management and employees. And so I think within that context, we can ensure that there is the appropriate representation of a diverse range of staff that are a part of that particular committee.
Right. I guess the question I have, if I may.
Yes.
Is that equal? Again, it says service worker, but you could have a 20 people and one service worker, right? You could have 10 staff, 10 administrators, only one service worker. And that's okay if that's what you're fine with. I thought, because I find that a lot of times hospital committees really just have a token person and they don't have significant input from. So I'm just curious about that balance, 50-50 administration and other. That seems that it's easy also to leave out, dietary and transport and, janitorial or, et cetera, lab. There are so many people who can be left out. And I'm just concerned about that, but you seem to be, and maybe I'll ask the question of you, are you comfortable that gives sufficient guidance that the people who you'd like to have represented are going to be represented?
I think that, in working together with a lot of the stakeholders, we worked really hard to make sure we were all on the same page to make sure these committees can even exist. When we look at other states, we have 9 other states that have implemented staffing committees, and you can see that in several years, they've strengthened what these staffing committees can do. So I think this lays the groundwork in Maryland. And once we start implementing it, we can find ways based on worker input, how to improve it and make sure that the process is as transparent, as collaborative as possible. But, at this first year that we're introducing it, we're really happy with the way we've been working with all of the stakeholders.
All right, that's all I needed to know. Thank you.
Delegate Johnson.
Thank you, Madam Chair. And thank you for the bill because something had to be done. And we do appreciate all of you workers. We know that you are the backbones and just know that you are appreciated. My question is on section E, page 2. When they develop the staffing plan and specific guidelines and ratios, matrix or grids indicating how many patients should be assigned to each registered nurse by unit or setting. And then it goes down to say the number of nurses, licensed practical nurses, certified nurse assistants. So if they establish this and then they can't meet this, what happens?
Okay. So it doesn't mandate an outcome, it mandates a process. And so this is really about making sure that there's as much collaboration as possible between management and workers. And so if they're not able to meet it, workers can come back, they have monthly meetings and talk about the different difficulties that they had in implementing it. And with management and with workers, they can find a solution that will work. So it's really about trying to make sure that there's feasible solutions moving forward. And with the process in place, you can try something out and have feedback and data that shows whether or not it works and come back to the committee so that there is an ongoing process.
Go ahead, Delegate.
The reason I ask, and thank you for the answer. The reason I ask is we know that we have difficulty hiring nurses and filling some of these positions, as some of the witnesses have testified. So I was concerned that it wouldn't affect the operation of a hospital. Okay, thank you.
Thank you, Delegate. Delegate Taveras.
I'm a little nervous to see, I think it might be similar to Johnson's question. How are you ensuring that there wouldn't be a limitation in services as due to these created plans?
So again, I don't believe that it would dictate or diminish the delivery of care, right? I think that at the end of the day, as was previously shared, this is about having a transparent and an accountable process by how we all the necessary and key voices and stakeholders can come to the table to inform what this plan will look like. So it's not necessarily, it is providing a larger goal. It's setting a goal and a plan for what it should look like. But there is no mechanism in the bill that requires or mandates that plan be executed with fidelity. It offers an opportunity to further strengthen it along the way.
Flexibility.
Absolutely. This is all about flexibility. And again, allows the hospital at the individual hospital level to determine what that is. And that's why it's so very important to have the committee meet on a regular basis to assess its effectiveness, to determine how well it is working, and thus make the necessary improvements moving forward to ensure that it can meet future goals.
Excellent. Thank you.
I think that's what you call feeding them the answer. Thank you, Delegate. Seeing no further questions, thank you very much for, I do have one question. I'm sorry, forgot. With the amendments, where are we with the other stakeholders?
So I cannot say, and again, you will hear that we have reached an agreement. But again, as I have mentioned in my testimony, that we remain at the table and willing to work, collaboratively to ensure that we can move forward in a positive way. But again, I still believe that there is unreadiness in moving this forward, despite making strides to address some of the initial concerns expressed.
Okay, thank you. Thank you for your work on this. Okay, I'm going to call up a panel of unfavorables, and that is Lynn Marie Verzino, Quinn Collins, Begin Townsend, Heather Beauchamp, and Brandon Floyd. And thank you all for hanging in there with us. We really appreciate your patience and your resilience. Who would like to go first?
I can begin, Madam Vice
Okay.
Chair.
Thank
Good
you.
evening, Madam Vice Chair, members of the committee. My name is Brandon Floyd on behalf of the Maryland Hospital Association, here testifying in opposition to House Bill 1194. We understand the overall intent of this bill, but have significant concerns as it relates to hospitals. This bill does not address the underlying issues with workforce shortages. Across the nation and Maryland specifically, hospitals have significant staffing vacancies. These vacancies are as high as 12% for registered nurses and as high as 37% for LPNs. Hospitals are severely understaffed and need the flexibility in real time to provide the proper care and ensure quality health outcomes. These mandated staffing plans will create challenges for hospitals to ensure that proper care and does not resolve the overall workforce shortages hospitals experience. Additionally, the bill will exacerbate hospital throughput challenges. It's been well documented that Maryland has some of the worst ED wait times in the nation. We appreciate the support of this committee and other committees in ensuring hospitals improve their throughput. Overall, we're concerned that these mandates via the staffing plans will create bottlenecks for patients. Patients will be unable to transfer from unit to unit because certain requirements will be in place for hospital staff based off the staffing plans. If patients are unable to be properly placed, it then leads to ED overcrowding and delayed throughput for many patients who are waiting in the emergency department. We have a panel of witnesses here, hospital representatives, who will testify in further detail on the concerns that we have with this bill. And for the aforementioned reasons, we urge an unfavorable report on House Bill 1194. Thank you.
Thank you. Who'd like to go next?
Excuse me. Good evening, Madam Vice Chair and members of the committee. I appreciate the opportunity to testify on HB 1194. My name is Quinn Collins, and I am the Senior Director for Nursing Strategy and Integration for the Johns Hopkins Health System. I've been a registered nurse and working in hospitals for more than 40 years. I am here in opposition to HB 1194, the Safe Staffing Act of 2024. While well-intended, this bill as written does not move us towards solving any of the clinical staffing issues hospitals face today. The Maryland healthcare workforce has experienced an increased number of vacant clinical positions since the pandemic. Clinical roles within the hospital setting are experiencing shortages anywhere from 9.2 to 36.6%. Hospital leaders have been working together on various initiatives that do address the workforce shortage. Hospital leaders continue their efforts to provide clinicians with the autonomy and professional growth opportunities they desire. This bill, as it is written, will limit clinical staff's creativity and innovation when working through solutions to staff shortages. These solutions include designing new models of care, integration of LPNs, use of nurse extenders, virtual nurses, robotics, and artificial intelligence assistance. Clinicians want input into how they staff and how they deliver care. At our hospitals, we have a shared governance model to ensure that we listen to staff, collaborate with them, and support them in order to provide optimal patient care. HB 1194 requires clinicians to quantify and report variances in staffing levels to HSCRC. Requiring staff to step away from clinical care limits the patient's access to their nurse. These variances occur because a coworker got sick or took a break or offered to take an additional patient because another patient experienced an acute change in condition. Clinicians embrace the culture of teamwork that is inherent in inpatient care. We need to support clinicians and assist them in implementing solutions to their issues, not burden them with administrative tasks while striving to deliver safe patient care. As such, I respectfully request an unfavorable report on HB 1194. Thank you.
Okay, thank you. Next, please.
Good evening, Madam Vice Chair, members of the committee. I'm Heather Beauchamp, Vice President of Nursing and Chief Nursing Officer at University of Maryland Rehabilitation Orthopedic Institute. I'm here today representing the University of Maryland Medical System, a system with 30,000 team members, 10 hospitals, 3 freestanding medical centers, and 150 locations to express our opposition to House Bill 1194, Safe Staffing. This bill, while well-intended, threatens to compound the challenges faced by our healthcare system. Mandating clinical staffing plans for hospitals may seem like a solution on paper, but in reality, it increases the complexity of hospital throughput. Legislatively mandating such plans handcuffs clinical team leaders, restraining their capacity management abilities and leading to bottlenecks that disrupt patient care. We've already seen the consequences of staffing shortages, bed closures, procedural delays, and cancellations. Maryland Hospital Association's employee vacancy data from February 2024 shows vacancy rates across crucial roles at concerning levels. Nurses, nurse practitioners, surgical technicians, and more, all essential roles are in short supply. In such a climate, flexibility in staffing is not a luxury, but a necessity. Consider University of Maryland Easton Hospital, where patients have waited in the ED for an average of 858 minutes before being admitted. In a geographic area where registered nurse vacancy rates have exceeded 30% at various times over the course of the past year, it's clear that rigid staffing mandates will only exacerbate the problem. Furthermore, the experts in the field, organizational leaders, and nurse managers argue against such legislation. We advocate for a dynamic approach to staffing, relying on clinical judgment and flexibility to meet the unique needs of each patient. Mandated ratios strip nurses of their ability to make real-time decisions based on patient acuity and resources available. Healthcare is rapidly evolving. Technology and interdisciplinary collaboration play increasingly vital roles. This proposal fails to account for these advancements. It ignores the variability among healthcare organizations and stifles innovation in care delivery. In conclusion, House Bill 1194 is not the solution we need. Instead of imposing rigid staffing mandates, let us empower healthcare professionals to make the best decisions for their patients. Let us trust in their expertise and commitment to provide safe, quality care. And thank you for all that you have done to continue to help us expand educational pipelines to grow the next generation of Maryland's healthcare workforce. Thank you for your time and consideration.
Thank you.
Thank you, Madam Vice Chair, members of the committee, Peggy Townsend, on behalf of the Maryland Hospital Association, opposition to this bill. We do support the intent of this bill. I think it's all our intent that we, hospitals and others, provide quality healthcare outcomes. That's the goal, right? Get healthcare outcomes to be as good as they can be. We don't quibble with that at all. But this bill, even with the amendments, doesn't account for patient flow changes that happen day by day, hour by hour, minute by minute. These changes happen in real time, and the folks on the ground have to make adjustments in real time. And that may mean not meeting the specific ratios that are called for in this bill. It also doesn't take into account the experience of a nurse or a care provider. A new grad is not anywhere equivalent to somebody who's been on the floors for 30 years. It's obviously one nurse does not equal one nurse. As I said, we reviewed the amendment. We don't believe they addressed our concerns. We just think having a static ratio in a staffing plan, and if we can't meet it, it will mean closures of services. I mean, that's what we'll have to do. And we've seen that in COVID when we didn't have enough staff. It does occur. And I would hate to see our ED problem further complicated by that. So for those reasons, we ask an unfavorable.
Okay, thank you. Questions from the committee? I'm going to start with Delegate Martinez.
Thank you, Madam Chair. And thank you all for your testimony. I really appreciated hearing that we can all agree we do have a crisis. We have something that we need to address. I was looking over the testimony submitted, and I didn't really see many suggestions on this bill on how we could amend or improve during the process, because we love collaboration in this committee. Did you guys submit amendments or suggestions to the bill sponsor on how we could get to an outcome we could be proud of?
Yeah, the problem is we have a fundamental disagreement of approach on this. We don't think static prescriptive plans without flexibility to adjust on a day-to-day, minute-by-minute basis is going to get us anywhere near the real problem, which is our workforce shortages. That's what we really need to focus on. Having a static plan, I don't think it limits our flexibility and innovation. And people are, because of the shortages, we're trying to piece things together to try to get more innovative solutions, like virtual nursing, for example. That's the latest and greatest. And I'm sure you all know more innovative things than I do.
I have Delegate Johnson.
Thank you, Madam Chair, and thank you, panel, for your testimony. It's kind of a two-part question. You heard me ask the question with the favorable panel about what would happen if they didn't meet the ratios. And they said there was no mandate. It was not mandated, so there would basically nothing would happen. But with this commission or this committee, it's my understanding of the bill that it wouldn't be just a committee until you come up with ratios, but it would be a continuous committee that would continue to work with the hospital to see where you could streamline or where you could solve problems or where you could double up. So I'm not understanding the comment about you would have closures. So I know that was a couple little things mixed in there, but if you could kind of address some of that.
You want me? Okay. Because it says that the hospital has to establish all these ratios for each of these types of workers on each unit during each shift. So if you're on the shift, night shift, and somebody calls out and you can't find a replacement, what do? It probably.
A question and say there was no mandates.
Well, I disagree. I can tell you, hospitals, if this bill passed and we had this, we would treat it as a mandate and would not want to violate the law.
Is that in the bill anywhere?
It said this will be in law that says you have to establish the number of folks.
I mean, any enforcement? Is there enforcement in the bill?
No, but we would treat it as a mandate. Make no mistakes. We would have to treat it as a mandate because it is in the statute. This is in the health general statute, and I'm sure there's general penalties in the back of that statute that talk about violations.
Okay. All right. Thank you. Thank you, ma'am.
Thank you, Delegate. I'm gonna go to Delegate Taveras.
Thank you. Well, Delegate Johnson asked one of my questions. Then, because I keep hearing conflate, you're putting your concern for flexibility with the mandate. And it's like, those two words really can't coincide in the same sentence. And we're hearing on one end that there is flexibility, and on the other end, you're saying no, that it's a mandate. So I think that there is inherent disagreement that y'all need to resolve regarding the language with regards whether it's flexible or not. And that's
I don't see anything in here that gives us flexibility.
And that's where the drafter of this bill disagrees, or at least the proposer of this bill disagrees, because she just said that there is flexibility. I mean, did you not?
I don't see anything on flexibility in the amended bill.
Okay. Can I just do a quick follow-up?
Yes.
Okay, thank you. The other concern that I have is that I do agree that we have had obviously extensive wait times. We have the longest wait times. Somebody cited here 14 hours. We were sensitive to that. But I would say, and maybe I may be wrong because I'm the new kid on the block, but I'm just assuming that there's been a lot of top-down type of look at this issue. And I would think that with the input of the staff from 1199, it would take a more bottom-up approach.
I can tell you that workforce is the top of mind issue for hospitals these days. And they are doing everything they can to recruit and retain the staff we need. Go ahead.
I hear what you're saying, and I believe you. I'm just saying that when we're trying to solve the problem, it has been the proposal for the recommendations have been top down versus bottom up. I mean, when you have somebody with 20 years experience, like the young lady that just spoke, I think that that's a different, as you said, that somebody said here on the panel that this having a 20-year-old experience is not the same as having somebody who just graduated.
Delegate Taveras, I think, this is a conversation we might be able to have later. But your point is, you've made your point. Whether or not it was heard, I'm not sure, but you've made your point. Delegate Hill.
Yes, thank you. And thank you all for being here. And I thought I was doing a Twilight Zone moment because the bill that you guys were testifying to wasn't the amended, and then Peggy, you said, no, you're talking about the
Well-
amended bill. And
And that was because we didn't get the amendments till last night. And these individuals had already,
right, and they
Re-
weren't able to modify.
correct,
Because
thank
while they
you.
sat here, right,
Yes.
I understand, because you're representing a group, and so you're not free to speak,
Yeah, on the
modify,
fly,
right,
if
you
you will.
can't speak on the fly because you're representing an organization.
Right.
I understand that. Okay, so if I may, I know, and you can tell me if I'm wrong, that when I've worked in hospitals for the last 40 years, there are ratios. There's a certain ratio on each floor, depending on what the nursing patient ratio should be and how many aides. So you guys work with ratios, right? That's not a new concept, right? Correct?
Correct.
And when
Guidelines.
guidelines, exactly. And when when you can't meet them, you just can't meet them. And you work to do better.
Correct.
But patients sometimes go and the nurses will complain that I'm supposed to have 3 patients, but I have 4, right? That
Correct.
happens all the time.
And that's not just in nursing.
Right.
Every area of the hospital, you couldn't build a budget otherwise, where you have guidelines on how many workers it takes to get the work done, right? So establishing staffing guidelines is very old news. That is not new. We do
Right.
that all the time, every year. So to get back to a prior point, if there's not repercussions, if there's saying there's no repercussions, we just want guidelines. There's no point in this. We already have guidelines. There's no need for this.
Well, the difference is that you guys, at least as I understand it, and my experience in hospitals is most of the guidelines are made from the top down. And you don't necessarily involve, like you involve nursing and nurse managers, and you may involve some physicians, but you don't involve everybody. And this is just saying.
We do, but you're right. You
Right.
can't, I can't speak for
And I
everybody.
think that's essentially the difference here. So like when I'm looking at your throughput solutions and the Maryland Hospital Association, it says April 28th, multidisciplinary experts from Maryland's hospitals and the Maryland Hospital Association began meeting weekly. And then it says hospital senior quality leads and ER operations directors and vice presidents. It doesn't say anything about workers. And so I don't understand how you can be so resistant to simply a bill that says when you're making guidelines and you're thinking about the problem, include everybody who's impacted within your facility, which is how I see this bill. And there's no mandate, just like when you can't meet the ratios on the floor with the nurses, nothing happens. The patients still go up, the nurses still complain, they figure out how to get it happen, but this is a mechanism to keep coming back and saying, are we making it? Is this the best policy? What are national guidelines? And how can we do better? But it's more input. And why do you not? So the question is, why is that not how you see this amended bill?
Because it's a mandate to establish the number of RNs, LPNs, CNAs, certified med techs, environmental service workers, and ancillary members that should be present on each unit during each shift. It says it right there.
Interesting, because the way I read it is when it says guidelines or ratios, matrices or grids, that means I could say, we'd like to have between 5 and 10. We'd like to have between 3 and 4. It doesn't say it has to be 10. It doesn't say it has to be 2. It gives you a huge flexibility to take into account all the things you've testified to that you need. And since you don't have any counter, other than to oppose the bill, you don't have any counter language. Okay.
It's a fundamental disagreement on
Right, okay. Thank
the
you.
underlying problem.
Thank you. Okay.
Thank you, Delegate Hutchinson.
Thank you, Madam Chair. I'm really having like some deja vu here tonight. I spent 25 years in healthcare working on clinical quality, patient experience, employee experience. We sold analytical tools that actually helped hospitals determine the right staffing. And isn't it true that it's based upon, the acuity, the average daily census, the experience of the staff, the number of staff that we can get? I mean, I never went to a hospital across this country where everybody said, we are fully staffed and man, we have everybody we absolutely need. So doesn't it really come down to, and when we did measure employee experience, it was always our recommendation to make sure you are including everybody at every level within to determine the right staffing. And I would think organizations like Johns Hopkins would currently be doing that. But in the end, doesn't it, you got to balance cost, you got to balance availability of staff. So doesn't it really become a leadership decision based upon all the data that have, the analytics you have? And then don't we have an oversight already in terms of the Joint Commission or the NCQA? I'm not sure who's right to answer that question. Maybe from Johns Hopkins.
Owners.
If the question is, don't we have oversight? We have ample oversight to all of that, to the quality, to the finances, to the numbers of staff, to how you meet your staffing guidelines. We do. It already exists today. And then some. State, local, Joint Commission, national. Yes.
Ms. Townsend, was there anything you'd like to add to that?
I think that's right. We have lots and lots of oversight and people coming through our hospitals all the time, looking at what we're doing and how we're doing it and whether we're delivering on that promise to deliver high quality outcomes. I would think that having this kind of mandate in a bill isn't going to get us to where we need to be. As Delegate Hill correctly said, nobody says they're fully staffed because they're not, and they have to make adjustments real time. And when we can't meet these ratios, we're going to treat it as a mandate and say, we got to make an adjustment and shift some patients or close some services.
Okay. Delegate Gazzoni, you get me, Delegate Gazzoni.
Thank you, Madam Chair. So, yeah.
Go ahead.
I'm not positive I have a question, but I will say that I'm looking at this language in the amendment. And what I see is developing a staffing plan with guidelines that should, and then the word should in both numbers 1 and 2. So that's where I'm struggling with regard to mandate, because those are all, should is nowhere near shall. I'll just put it that way. So isn't that so, I guess, is where I'll leave that.
We would treat should as a shall. This would be in statute, in the hospital section of the statute. And it's guidelines or ratios.
Otherwise, it's not necessary.
So just how we would see it.
Okay, Delegate Bandari, followed by Vice Chair Collison.
Like deja vu.
Thank you, Madam Chair, and thank you for meeting with me as well. If I understand your concern correctly, you guys are saying that if there is no hospital flexibility, it will worsen emergency room wait times due to rigid staffing ratios. If I understood correctly, that's your argument. In the meantime, the empirical evidence suggests that structured staffing plan not only improve patient outcome and staff satisfaction, but may also address the root causes of the healthcare workforce crisis by creating a more supportive and sustainable working environment. So what is the committee would like to know, how do you do, what is the practice now? What is your current practice? How do you do those staffing? Could you share that a little bit?
I can speak for University of Maryland Medical System. We have a shared governance structure where we have frontline staff, and I'm representing nursing, of course, but on the nursing side, we involve patient care technicians, our LPNs and our RNs to come up with our shared staffing model. We're currently in budget season. We have reviewed these staffing models with them, which are a staffing matrix we use that have a demonstrated or suggested ratio. There's flexibility in that where they would need to go up if we have admissions. and previously to working at Kernan, or University of Maryland Rehab and Ortho, I was the assistant vice president over the emergency departments at Hartford Memorial and Upper Chesapeake. And when you have a mass number of patients come into the emergency department, if those nurses upstairs have a set ratio where they will not flex, then we cannot get additional admissions upstairs, particularly if there's a call out or other short staffing reasons. So we just ask that it's not mandated, but that we maintain that flexibility. And I would always encourage that we have the structure to have our bedside clinicians at the table. And part of that, I myself I've always been employed at University of Maryland Medical System. That's been our standard since I started back in 2006 there. I was part of that shared governance structure. I've taught as adjunct faculty at Hopkins, so I can attest that that's part of their structure as well. And I do believe in deference to expertise, that's where we learn best. The boots are on the ground, but I worry that when things are mandated, we won't be able to accommodate the needs of our communities.
Vice Chair Collison. Thank you, Madam Chair. So I want to offer, I think, sort of a concept that Delegate Tavares was trying to convey, in that Delegate Bandari just said it fairly well, that your employees are the greatest assets you have. And if you don't take care of those assets, they're going away. And I heard a report that was done in December of 22, when we had a briefing from the hospitals saying they couldn't keep their staff, and they did all this reasons why. Salary was just barely above climate, work climate, working conditions. And the way that you learn about climate and working conditions is by incorporating, and I hear that there's some, but this would give this, what's being proposed here is, would give real credence, and the whole staff would feel engaged and involved and valued in the processes. And I want to push back on this notion of rigidity around these staffing ratios, because I trust the people who are actually doing the work every single day to be able to give you information around how to be flexible. So I guess I am as confused as my colleagues are here on the committee around why you think this would be so challenging. And I think if you look at some literature on hospitals and the hospitals that have these kinds of committees, and for this bill, it's limited to staffing. I mean, I'd like to see it to all elements of operation of the hospital, but maybe this is a first step towards it. And certainly improving our hospital staffing is absolutely a priority for all of us. Well, again, I'm going to venture that it's not just about salary. People are going to stay where they enjoy and where they enjoy working, where they feel valued and respected. So I don't know that I have a question, Madam Chair, and I'm sorry I've ranted, but I felt really, isn't that so?
There is a question by Delegate Johnson, then White Holland.
Thank you, Madam Chair.
My pleasure.
I'm a little confused by some of the comments. I wondered if you guys could clear it up for me. So you said you already have staffing charts.
Staffing charts, is that what you said, sir?
So, okay, so do you not consider those mandates? And if you can't man those specifically to your own staffing charts, do you shut things down?
To answer your question, we consider those to be guidelines that we distribute on the unit and with the input of our shared governance model. So each of our units represents that staffing plan, and we review that annually. We have bed meetings twice a day in our organizations to review our staffing and try and supplement them if they have short staffing needs. But in extreme circumstances where maybe you have multiple critical care patients, you have to go outside of those ratios, and we do our very best to staff to our suggested guidelines on those ratios. But there are some days where we cannot meet that need, and that would mean that other patients in the community would suffer.
Okay, but you said you would consider these mandates, and if you couldn't follow those, you would have to shut things down. So do you not consider your own staffing charts mandates?
No, guidelines.
Okay, all right. Thank you.
Why, how?
Thank you, Madam Chair, and thank you all for your testimony. I believe you just utilized the word suggested, right, guidelines. And so given the amendments, which I understand you may not have seen, but I know I shared those with our colleagues with the Hospital Association. I know in provision, it says specific guidelines. If we were to replace that with suggested guidelines based on the language in which that you use, would you all be open to being in a different position, given that, again, similar to Delegate Johnson's point, that this, if anything, would, if anything, build upon the existing processes that many of your hospitals already have in place, just ensuring that there is a greater diversity and more representation of the voices that inform the process. And so is using the terminology suggested guidelines per, your response would be something that you all would be open to?
We can take a look at that.
Okay, thank you.
Okay, so there are no other questions, but I had to get up when this hearing started because as the chair, I have different meetings with people, right? This is a time where everyone is worried about their bills. So I have many meetings, but I can read a room, right? And I wasn't here for the whole time, but my gut and I can feel and read a room. Can you read the room? Tell me, what is the room telling you?
They don't care what hospitals say.
Excuse me? No, go ahead. Tell me what the room is telling. Peggy, go ahead. Tell me what is the feeling of the room?
I can see the room. Yeah.
Right? And you feel the same way?
Yeah, there's been several.
And
of these.
can you read the
Fine
room?
sections.
Okay, so if you could read the room and you can feel the room, could you imagine what your workers feel when this goes down and how it affects the morale? Is it worth it? Especially when it's drafted broadly, because this is about creating a plan and it gives you certain things to include, but it's not so prescriptive that you're tied to whatever is in there. So I would give you some advice, gentle advice and respectful, that you sit down with the sponsor and figure out language that you can live with. But choose wisely, because you can tell the room here how we're feeling. Imagine your employees in a time where nurses and healthcare workers are tough to find. And the morale affects you. If you go into a place and you don't feel right, trust me, you're not gonna get the max out of those employees, even if they care, because you want to be appreciated. That is, it's a human need, okay? Thank you.
Thank you.
All right. This actually concludes the bill hearing on House Bill 1194. And for the committee, if you could stay seated for a minute, please. And if I may ask the hospitals, if you can make yourself available, please. Delegate White Holland is available now, okay? I would want her to talk to you. The conference room